management principles. Over to you, Sunita.
Okay. Thank you, Dr. Mathur. So at the outset, I would like to thank Dr. Hunawar and the CSF team for having me here. So my topic for today is angle closure disease, terminology, diagnosis, and management principles. It's not moving. Slides. Okay. So as we know, angle closure glaucoma is the leading cause of blindness worldwide, and it is much more common in Asia, and 87% of the angle closure glaucoma patients belong to Asia. If you look at the glaucoma prevalence worldwide, the prevalence of PACG is almost half of that of POAG, but PACG is much more blinding than PACG, and almost the blinding rate was 1:1, and the percentage is 33 to 75% of contributing to the pathogenesis of angle closure glaucoma. So basically, it's the interplay of multiple anatomical and physiological factors. So we know already that in angle closure glaucoma, there are a lot of anatomical factors that play an important role in causation of the disease, like shallow anterior chamber, decreased anterior chamber volume, then factors related to iris area curvature, lens-related factors, increased lens vault and position, and ciliary body-related factors. So along with anatomical factors, there are altered physiological factors or the dynamic factors which can lead to increased prevalence of angle closure glaucoma. So these are the four mechanisms which are important, and the most common mechanism is the pupillary block. So we all know the pupillary block mechanism, which is the most common mechanism for causation of angle closure glaucoma. So what happens in pupillary block glaucoma? So as you can see in this picture of UBM, we can see it very clearly that there is a resistance to flow from posterior chamber, from the posterior to the anterior chamber because of the block at the pupillary area. And as a result, there is bowing forward of the iris, and this will cause occlusion of the angle because of the crowding of the iris at the angle. So this is the mechanism of angle closure because of pupillary block, and this is called relative pupillary block. When there is just an appositional closure, it can become absolute pupillary block when there is synachial closure. So whether most of the glaucomas are because of pupillary block, it is not so true. Some of the angle closure glaucomas could be because of the non-pupillary block mechanism, which we are going to discuss. And there can be a combination of pupillary as well as non-pupillary block. So as we know, lens is pivotal in causation of both pupillary block as well as angle crowding. So it plays a very important role in causation of angle closure. And as you can see in these pictures, because of the increased thickness of the lens or anterior positioning of the lens, there is blockage of the aqueous outflow. Another factor is lens vault, which we now better understand with the advent of ASOCT, where we can actually see how much is the lens vault. And in eyes with angle closure, they have thicker and anteriorly placed lens with increased lens vault, and which increases the risk of angle closure by 48 times. So I think this is one of the most important factors which you should look for when the PI doesn't relieve the pupillary block. So if you look at when we advise anterior segment OCT and when we measure the lens vault, we definitely have a clear-cut difference between the normal eyes and the eyes with angle closure glaucoma. So the lens vault normally is 300, 400, but in these eyes, it is as high as 900, 1000, and maybe more than that if it is associated with nanophthalmos. So I will not be covering nanophthalmos, but there is a possibility that these eyes may be associated with nanophthalmos, which is associated with decreased axial length, increased thickness of the lens. Also, with advancing age, the lens thickens and there is forward displacement, and especially in eyes with angle closure, there is 1 millimeter shallowing of the anterior chamber because of the increased lens thickness and forward lens position. So lens plays a very important role in causation of angle closure glaucoma. Now coming to diagnosis, apart from history, I think one and very important diagnostic test is gonioscopy. It is indispensable in differentiating between the angle closure and open angle glaucomas. So you have to look for various factors like pigmentation of trabecular meshwork, shape of the iris, presence of PAS, and level of iris insertion, which you can easily diagnose with the help of gonioscopy. However, it is mandatory to perform indentation gonioscopy, and this will help you to differentiate between appositional and synachial closure. So if you are able to see the angle properly after indentation, as you can see in this particular patient, here you cannot see any angle structures, but when you indent with the help of 4 mirror gonioscopes, then you are able to see the structures up to scleral spur, and that means that there is appositional closure. And this patient is going to be helped by laser PI. We also use UBM and ASOCT to understand the pathophysiology is better. And when you compare open versus closed angle, in the UBM pictures you can see here, there is a definite difference between the angle configuration, the iris curvature. You can see here the eye which has a closed angle has high iris curvature, and there is crowding of the iris at the angle, and in this eye it is relatively open, and you can see that the iris curvature is flat. And here you will see the distension of the posterior chamber because of the high pressure in the posterior chamber. Again, you can see this iris convexity here blocking the angle. Iris thickness. So we have seen when we tend to perform laser PI in patients with angle closure glaucoma, it is very difficult to do laser PI, and it is because the iris thickness is definitely more in these eyes, and which is responsible for causing the angle closure. And you see this eye and this eye, there's a clear-cut difference between the iris thickness, especially at the insertion of the iris. And then the plateau iris configuration, which is the common cause of non-pupillary block glaucoma. Here, the iris takes a sharp turn at the mid-periphery, as you can see here, and which cause blockage of the angle. And when you do gonioscopy in eyes with angle closure, with plateau iris, you will see this sine wave sign, wherein you will see elevation at the mid-periphery of the iris because of the because the iris gets pushed by the ciliary processes, as you can see here, and it can be beautifully seen by UBM. So if you want to diagnose plateau iris, then you have to perform UBM. So these are some of the differences between the pupillary block and plateau iris. So in pupillary block, as you can see, the AC will be almost flat, but in plateau iris, since the elevation is the mid-periphery, the central iris, AC depth may be normal, and the pupillary block, as we know, is relieved by iridotomy, whereas the plateau iris will not get relieved by iridotomy. So you have to then perform another procedure. Now, how do you classify angle closure disease? So we know that it's a spectrum of disease which starts from primary angle closure suspect, or just narrow angle, primary angle closure glaucoma, and acute angle closure. So in PACS, which we very commonly see in our OPDs when we have, out of 10 patients out of 100 patients, or 1 patient out of every 10 patients will have angle narrow angle, some amount of narrowing of the angle, and they will not be diagnosed unless you perform gonioscopy. So when you perform gonioscopy, you will not have the view of the PTM for more than 270 or 180 degrees. However, there is no evidence of the disease. In PAC, there is some evidence of past high IOP or angle closure, and therefore you will get some pigments in the angle, or maybe some PAS, and IOP may be high or low, but again, there will be no disc or field damage, because we call it a glaucoma only when there is disc and field damage associated with angle closure or synechia. Acute angle closure, all of you must have seen the patients with acute angle closure. There is sudden elevation in the pressure, which is associated with blockage of the entire 360 degree of the angle, causing corneal edema and complete blockage of the angle on gonioscopy. So it will have classical signs and symptoms. I'll just like to share this case who presented to me 8-9 years back, and he came to me with a pain, redness, and decreased vision in both eyes of 1 day duration. The visual acuity was 4/60, 3/60. The pressures were very high. And fundus, when I probed the history in detail, he said that he was dilated a day before in our own hospital. That time his vision was 6/6. He was high hypermetropic, as you can see here. The pressures were normal. And he had all the signs and symptoms of the angle closure glaucoma. As you can see here, corneal edema, dilated pupil in both the eyes. He had acute angle closure attack. And why? Because we had missed, the doctor who had dilated the patient, or the optometrist who had dilated the patient, missed doing Van Herrick's, which is very essential. You can just do it on the slit lamp. He forgot to do the gonioscopy or axial length of the eye. So I think these things are very, very important. A thorough clinical evaluation is very important if you want to diagnose angle closure glaucoma. And a simple PI in such this particular case could relieve the pupillary block. So gonioscopy has already been taught in the morning session, so you have to look for the corneal wedge, and you can see here that the beam which is dipping behind the iris. That means the angle is closed and this angle is open. And here this is the pigment which is there anterior to the Schwalbe's line. So you have to avoid undue pressure on your gonio lens, and also avoid throwing light on the pupillary area, which can lead to opening of the angle, inadvertent opening of the angle. So you have to perform gonioscopy to properly to diagnose angle closure glaucoma. And again, as I said before, dilating the patient, at least look for Van Herrick's sign. And if the Van Herrick's is shallow, then you have to do the gonioscopy. And then you can also look for subtle signs like loss of pupillary rough. Now coming to management principles. So these are the options which we all know are available to manage angle closure glaucoma: laser iridotomy, laser iridoplasty, goniosynecholosis, lens extraction, combined surgery, or filtration surgery. Now coming to the laser peripheral iridotomy, as we know that it is the definitive treatment for a pupillary block. And we have been doing laser iridotomy for all our patients, as it eliminates the pressure differential between anterior and posterior chambers, and it appears to alter the natural course of the disease. But the question is, do all PACS, all suspects or occludable angles need laser PI? I think this is a very valid question. And who is at the risk of progression to the next stage of the disease? And what is the use of laser PI in chronic PACG? So several studies have been done, and the study which we commonly read shows that only 20 to 25% of the patients progress to the next level. So not all patients progress. And I said that in an OPD, at least 10% of the patients have narrow angles, but the prevalence of angle closure glaucoma is just 0.5 to 1%. So that means the progression to the next level of the disease is very, very less. So you do not, ideally you should not be requiring laser PI to prevent angle closure. And so this ZAP trial, I think, which is a very logical trial, and which gives us some answers, and it was conducted with the aim to assess the efficacy of laser peripheral iridotomy in preventing development of primary angle closure or acute angle closure in Chinese people with primary angle closure suspects. So it was conducted both in China as well as in Singapore. So it was a randomized controlled clinical trial, and the patients were randomized to either LPI in one eye and no treatment in the fellow eye. So the patient was, the control was also the other eye of the patient, and then the patients were follow-up. 900 patients were recruited. They were follow-up for 2 weeks 6 months, 18 months, and then up to 72 months. And during that period, what were the outcome measures? If the intraocular pressure measurements went above 24 millimeter mercury on 2 occasions, if there was development of at least 1 clock hour of PAS in any quadrant, or an episode of acute angle closure. So these were the criteria for the progression. So if you look at the numbers, in LPI group, the eyes which underwent laser peripheral iridotomy, 19 eyes out of 900 eyes progressed, and in no treatment group, 36. So if you look at this figure, there was 50% risk reduction. But actually, if you look at the raw numbers, the numbers were pretty low. So the study concluded that, or recommends that, the risk of future angle closure glaucoma is low with laser PI, but acute angle closure can develop in some eye, but it is again very rare. So it is not a very common finding to develop acute angle closure if PI was not performed or the pupil is dilated. So community-based screening to identify primary angle closure suspects and perform laser PI is not recommended. So there was a belief that one should do laser PI in all patients of occludable angles, but this was not recommended by this study, and this study recommends against the widespread practice of laser PI in angle closure suspects, and this practice is likely to save considerable time and money to avoid unnecessary medical intervention. So you don't need to actually go and screen for angle closure suspects in the community. And the major strength is that one eye of each patient acted as its own control. So I think that was a major strength. So in which cases would you like to do the laser PI? The patients who have PSC or PSEG in the fellow eye, or who need repeated dilatation, or there's a family history. So it's very important to do laser PI as soon as possible of the patients who have had acute angle closure glaucoma. We do not do peripheral iridoplasty in many cases. There is paucity of data, especially in India. However, it is effective in Plateau iris. Now coming to the lens extraction, or clear lens extraction rather, and it's a very controversial topic, and it is a logical topic because lens determines the iris profile, angle configuration, and it should be a logical choice. And if you look at these pictures, then the lens extraction causes deepening of the angle, and it is helpful in the lens vault also. So again, this Eagles trial, which was basically done to see whether clear lens extraction was effective in patients with primary angle closure or early primary angle closure glaucoma, or whether it was superior to YAC PI. So it was conducted, it included 419 patients. So 204 were subjected to clear lens extraction, and similar number of patients to PI. So after 3 years, it was seen that clear lens extraction group had achieved a significantly lower IOP and was on fewer medications. And in fact, the patients with laser PI and medication require further surgery. And 16 of the 24 patients with the laser PI group underwent lens extraction for the clinically relevant cataract over a period of time, and some underwent trab and tube also. So the conclusion from the study is that laser PI as the initial treatment for angle closure should be reconsidered. You need not again to re-emphasize that you can consider lens extraction in some of these patients, especially in patients who are elderly and have early cataract also. And this procedure is even cost effective. So just to recapitulate, when you get a patient with primary angle closure disease spectrum, you have to first identify and document the occludable angle. You have to document the iris configuration. You can do laser PI if indicated, as we have already discussed. If the angle is widened and little or no appositional closure is present, then you can just continue with the expectant approach. However, again to re-emphasize, if the patient is having even little bit of cataract, he is high hypermetrop, he is elderly, they will benefit from early lens extraction. And however, So the threshold for lens extraction is low. However, when the synachial angle closure is extensive, say more than 2 to 3 quadrants, simple lens extraction may not suffice, and you can do a combined trab with phaco or any combined surgery. So the take-home messages are that you need to understand the stages of the disease properly, and that is the key to early intervention and prevention of damage because of angle closure glaucoma, which is a blinding disease. Laser iridotomy holds promise to prevent the development of vision-threatening complications, but you may not do it in each and every patient. You have to select your patient, and lens phacoemulsification alone shows great promise, especially if there is early cataract in elderly patients for control of IOP and progression in patients with this devastating disease. Thank you very much.
Thank you, Dr. Sunita, for that comprehensive overview of primary angle closure disease spectrum. Now I would like to invite Dr. Amit Pandey for his talk on open angle glaucoma, normal tension glaucoma, and ocular hypertension, terminologies and diagnosis. Dr. Amit is a young glaucoma surgeon who hails from CFS, Surat, Gujarat.
Good morning, everyone. Thank you, iFocus, for calling me for this talk. I'll be talking about terminologies and diagnosis per se. It's a very vast topic, but I'll try to cover it in the given time. To start off with, you already know glaucoma is a heterogeneous, chronic, progressive group of eye diseases which is characterized by optic nerve head atrophy, loss of retinal ganglion cells, and typical visual field changes. Open angles, when gonioscopically you can see posterior trabecular meshwork in more than 180 to 270 degrees. Those are open angles. And primary glaucomas are when it is idiopathic condition. There is no secondary ocular or systemic causes. Pathophysiological classification, we divide it into primary and secondary glaucomas, then gonioscopically open and close angles. In open angles, congenital and non-congenital, that is adult glaucomas. Again, in adult glaucomas, we go ahead and divide it into either primary juvenile onset glaucoma, primary open angles, or ocular hypertension. Then further, in primary open angle glaucomas, it could be a high tension or a high pressure glaucoma, or a low pressure or a normal tension glaucoma. We'll be covering these. Starting with normal, or better term to describe this condition is low tension glaucoma, is a form of an open angle glaucoma which is characterized by glaucomatous optic neuropathy in patients where consistently you are getting intraocular pressures less than 21. It has to be a Goldman applanation tonometry and at least 2 readings which are 2 weeks apart. The Beaver Dam study reported nearly 1/3 of glaucoma patients could be classified as NTG, but I think it's an overestimation. Practically, we get around 5 to 10% of our glaucoma patients to be NTG. Etiology, because it's a primary glaucoma, it's unclear, but the contributing factors are vasospastic events, hypoperfusion, nocturnal hypotension, and it has been associated with migraine, other Raynaud's phenomenon, cerebral ischemia, and other autoimmune diseases also. So to differentiate normal tension and high tension or POAG, in NTG, there is a higher propensity of optic nerve damage relative to the low levels of IOP. Even in visual fields, you get a deeper, steeper, and closer to fixation loss in NTG as compared to POAG, as you can see here. The amount of visual field loss is also greater when we see the optic nerve head appearance in NTG. In NTG, you get more localized RNFL defects also, and there's a higher propensity of optic disc hemorrhage as compared to POAG patients. It's a diagnosis of exclusion. When you have excluded everything else, only then you can say that this is an normal tension glaucoma. What things you need to rule out is other types of glaucomas. One is burnt out glaucoma, where in old age the IOP tends to become lower again, but the damage has already happened. So when the patient comes to you, you feel it's NTG, but it could be a burnt out glaucoma. POAG with diurnal variations, where you are not able to detect the high intraocular pressures. Similarly, in intermittent angle closure also, where IOPs are becoming high sometimes during the day, Secondary open angle glaucomas such as pigmentary glaucomas where exercises or other activities would lead to an increase in IOP and then it would come back to normal again. Thin central corneas, again, especially patients who have undergone a refractive corneal surgery, you might get a falsely low intraocular pressure. We need to rule out other diseases of the optic nerve like ischemic optic neuropathy or disc pits, etc., which would mimic a glaucomatous damage. And because NTG is a bilateral condition, patients with unilateral optic neuropathy should be, other conditions should be ruled out. Coming on to ocular hypertension, it's sort of opposite of NTG where the intraocular pressures are high, but there is no optic nerve head or visual field damage. OHTS was a landmark study which showed us that in 5 years, around 10% of patients from OHT would progress to open angle glaucoma, and with a 20% IOP reduction with medicines, that rate would decrease by half. The risk factors that came out of this study were increasing age, increasing IOP, decreased thickness of the cornea, and increased cup to disc ratio. So the stages of glaucoma would be biomechanical changes that would happen first, including increase in the intraocular pressure, which would lead to structural changes like increased apoptosis, RNFL changes, which again would be translated to visual field damages. Pre-perimetric, mild, moderate, severe perimetric damage, and then complete blindness. Coming on to the risk factors, it's very important to evaluate risk factors for diagnosis of open angle glaucoma. Increased intraocular pressure, of course, is one of the most important risk factors. Applanation tonometer is the gold standard still. Family history of glaucoma is again important. Age more than 40 years. Thin central corneal thickness is an independent risk factor for diagnosis as well as progression of glaucoma. It's very important. Other risk factors are high myopia, diabetes, hypertension, history of ocular trauma, and corticosteroids needs to be ruled out for other secondary causes. This is the summary. And then you come on to a suspicious disc. So these points are for an open angle glaucoma suspect. Remember this. Suspicious discs, I think this has been evaluated. Disc size is very important. You can have cup disc ratio discrepancy, but when you see the disc size in these two cases, the disc of the left eye is larger and hence the cup disc ratio is also more. It's not a glaucomatous damage. Disc shape is important. When you have a normal disc is a vertically oval disc, you can have a torted disc where the disc is inclined from the vertical axis more than 15 degrees, and you have a tilted disc when anterior-posteriorly the disc is tilted, right? So these needs to be evaluated. The cup and rim margin is very important to evaluate stereoscopically. The blood vessels in the optic nerve head would help us in that. The neuroretinal rim is probably the most important parameter in the optic disc evaluation, like has been discussed. Isn't rule has been discussed, and the isn't rule is followed in the glaucomatous damage also. So inferotemporally and superiotemporally, first the damage would start, then the nasal, and then the temporal. RNFL defects is a very strong indicator of glaucoma that needs to be evaluated in red-free, and disc hemorrhage again is it signifies progression of glaucoma. There you go. Diagnostic tests in open angle. Anterior segment imaging is more for angle closure, like madam has already discussed. The others are discussed briefly. I'm going to skip anterior segment imaging because it's, yeah. Central corneal thickness. As we know, thick corneas, overestimation of IOP. Thin corneas, underestimation of IOP. Easy to remember. Thicker, more, thinner, less. Exception to this rule is corneal edema, where you have thick corneas, but you underestimate the IOP because the water inside acts as a cushion. Their correction factors are still being used for IOP correction, but World Glaucoma Association consensus now says that correction factors should not be used to adjust the values of IOP because there's a huge variation that happens in normal individuals, glaucoma and angle closure disease as well. So same correction factor will not hold true for everyone. But yes, CCT helps us to interpret the IOP reading where if we are overestimating or underestimating it. And again, it helps to stratify the patient risk for ocular damage. It's an independent risk factor for development and progression of glaucoma, and all glaucoma suspects should undergo a CCT evaluation. Visual field testing, automated static threshold, white on white perimeter is still the gold standard. Every patient should undergo a baseline visual field analysis. 24-2 CETA standard again is the choice in most mild to moderate glaucomas, and in severe and advanced glaucomas we need to do a 10-2 error macular threshold as well. The characteristics are localized, reproducible, asymmetric, or across the horizontal meridian. That is, the visual field loss, it respects the horizontal meridian here, whereas in neurological diseases it respects the vertical meridian. It is located usually in the mid-periphery. It's not attributable to other pathologies. You need to rule out vascular occlusions in the retina, other retinal pathologies, and only then you can characterize this as a glaucomatous visual field damage. And we should always correlate with the optic disc and neighboring area findings. Anderson's criteria, I think it has been discussed or will be discussed. These are the usual characteristics of glaucomatous defects that you see in your OPD. Progression, again, compare the selected baseline, you discard the learning fields from the baseline, and you need to recognize false progression. Guided progression analysis is the way to go ahead, and it is compatible with both CETA and full threshold. This is how a GPA printout looks like. The limitations are, it takes around 25 to 30% of RNFL retinal ganglion cell loss to happen before a standard perimetry could detect a damage, and hence we are losing a lot of time there. So we need something to evaluate a pre-perimetric glaucoma, for which FDP and SWAP, that is short wavelength automated perimetry, were developed, but many studies have demonstrated no clear advantage now, and it's more of a theoretical question. Another recent advance that you can mention in your exams is virtual reality or eye tracking perimetry. That is becoming popular now. Stages, you have mild to moderate glaucomas where there is optic nerve abnormality but no visual field damage, or we can see damage only on SWAP or FDP. Moderate stage glaucoma where you have optic nerve head damage, you have glaucomatous damage but only in one hemifield and not within the 5 degrees of fixation. Then you have advanced, late or severe stage where you have all three. Optic nerve head imaging technologies, madam has already, I'll just brief through it. Stereoscopic photographs, you need a stereo viewer, and there is high inter and intra-observer variability. Computerized disc imaging was developed, OCT, interferometry, HRT, confocal scanning laser ophthalmoscopy, GDX, scanning laser polarimetry. Again, this has been discussed. The radial scans, line scans through the optic disc to give a cross-sectional information of the cupping and neuroretinal area. Disc margins are objectively identified using the signal from the RPE, and these are the parameters that are evaluated, and we are given a color-coded, age-matched printout of the optic nerve head. You have guided progression analysis in OCT as well. This is how the printout looks like. You need to identify this. This is the HRT printout and the GDX printout. More recent advances that you can mention again in your exam papers is pattern reversal ERG and multifocal ERG, which may one day help in detecting pre-OCT glaucomas as well. To summarize, if you have a glaucoma suspect, you do a complete clinical evaluation, you do a white-on-white perimetry, you do gonioscopy, reveal open angles, and secondary causes are ruled out. If the intraocular pressure is high, you do a central corneal thickness, and if disc findings are there, visual field damage is there, which is correlating, you are dealing with a primary open angle glaucoma. you need to do a visual field for follow-ups as well. You need to treat those patients and do a perimetry for follow-ups. When these changes are present, but visual fields are normal, you are dealing with a pre-perimetric glaucoma. There an OCT would be a better technique, better test. And if you have a normal disc and visual fields, you are probably dealing with a ocular hypertension. There also you need to rule out if the patient is progressing to glaucoma at that stage or not, and OCT would be a better tool there. If the intraocular pressures are normal, here, the disc changes are present, visual field damage is present, again you do a CCT and you also do a DVT, a diurnal variation test. If intraocular pressure on DVT comes out to be higher, then you are again dealing with POAG and perimetry would be sufficient. Whereas intraocular pressure, if it's consistently low, even on DVT, you are dealing with normal tension glaucoma. And perimetry, again, you need to rule out the systemic causes there. To conclude, clinical examination is still the mainstay of glaucoma diagnosis. Standard automated perimetry is the gold standard. There is no single imaging device that outperforms the others. And identification of glaucoma does not depend upon a single computerized imaging device. Rather, the clinician's judgment as based on a combined findings from optic disc, RNFL, visual fields is integral for diagnosis, right? So you need to use all weapons in your armamentarium, and the most important diagnostic tool is your brain. Use it. Thank you.
Thank you, Dr. Amit, for that lucid interpretation between open-angle glaucoma, normal tension glaucoma, and ocular hypertension. Thank you very much. Now I call upon the next speaker, Dr. Debashish Chakravarti. He's a cataract and glaucoma surgeon from CFS Kolkata. He has been the chief instructor of many instruction courses at IIOC and contributed many chapters in different textbooks. Over to you, Debashish.
Thank you, sir.
He shall be speaking on developmental glaucoma.
At the outset, I would like to thank the iFocus team, Dr. Shantosh Sonavar, Dr. Mahipal Sajde for giving me this opportunity. So it's a huge topic I would like to cover in brief. So developmental glaucoma, although rare at times, you will encounter them not only in your exams, but in your future life as ophthalmologist as well. Maybe those who pursue pediatric ophthalmology or glaucoma surgery in future will do surgeries on developmental glaucoma, but it's absolutely essential not to miss out on developmental glaucoma, because the earlier you refer to these children for surgery, the better is the prognosis. So for making this presentation, I have taken the help of these resources. This is a World Glaucoma Association Childhood Glaucoma Consensus Series, and this is a book on pediatric glaucoma by Dr. Anil Mandal and Dr. Peter Netland, and this IGO article published in 2011. So childhood glaucoma is an umbrella term, and the CGRN, or the Collaborative Glaucoma Research Network, they have established a lot of these definitions and consensus as to what should be the approach towards managing pediatric glaucoma. So basically, it's a heterogeneous group of diseases which are characterized by elevated intraocular pressure and optic disc cupping, and this is primarily a surgical disease. So the definition of glaucoma, as you know, in adults, the pressure is important, but in children, the measurement of the pressure is sometimes tricky because you measure them during an EUA, examination under anesthesia, and there so many factors come into play. So optic disc cupping, again, and most importantly for children, there are two factors that you have to take in consideration. One is the corneal findings, because the glaucoma appears at an earlier age, there is progressive enlargement of the eyeball. This leads to typical findings, which are the breaks in the Descemet's membrane, which are called the hub striae, and an enlargement of the eyeball size. Now, what size of enlargement is important? More than 11 millimeter in newborn, more than 12 millimeter in a child of 1 year of age, or more than 13 millimeter in any age. If you find any child with this large eyeball size, always keep congenital glaucoma or developmental glaucoma in mind. Then another is progressive myopia. Despite a successful surgery, a child's IOP may progress in future, and if you find that a child who has undergone glaucoma surgery in the past is developing progressive myopia, again keep in mind that IOP might be rising. And then reproducible visual field defect when it is possible. Now, again, to classify the glaucomas, we take help of the CGRN classification. Primary childhood glaucomas are the primary congenital glaucoma, or the PCG, and the juvenile open-angle glaucoma, or the JOAG. And then we have the various types of secondary childhood glaucomas. Now, what are maybe the secondary childhood glaucomas? This can be associated with an acquired condition. Most commonly, the causes we see in India are the uveitis, trauma, steroid-induced, very common, steroid-induced glaucoma in children. Then some tumors, even retinoblastoma can be misdiagnosed as congenital glaucoma and vice versa. Glaucoma following cataract surgery is very important. And regarding the glaucoma associated with the non-acquired ocular anomaly, the important ones are axonfeld rigor anomaly, Peters anomaly, and aniridia. And regarding the glaucoma associated with the non-acquired systemic disease or syndrome, important causes would be Down syndrome and Sturge-Weber syndrome. Now, to classify these glaucomas into the particular category, it's not difficult if you do a comprehensive eye examination and if you take a proper history. Now, what is the most common type out of this, all these types of glaucomas? The primary congenital glaucoma, the PCG, is the most common type. Now, we will discuss in detail about the primary congenital glaucoma as it is the most common, but I will just touch upon the other common secondary glaucomas or the other types of developmental glaucomas that you see. So, for example, this is juvenile open-angle glaucoma. It typically presents after the age of 4 years. There is no ocular enlargement, often inherited as autosomal dominant, and the problem is that these children can appear in a very advanced stage of glaucoma. They can have very high IOP, up to 40 to 50 millimeter. The angles look normal. The eyeball size is normal, but there is extensive optic disc excavation and very advanced glaucomatous field defect. Then what is this, can you diagnose from the picture what is this condition? This is axonfeld rigor anomaly. So there is a prominent Schwalbe line which is called a posterior embryatoxon. There are characteristic changes in the iris, which are the iris atrophy, iris holes, and correctopia. And if you do a gonioscopy, you will find that there are broad bands of iris tissue adhering to this prominent Schwalbe line. And in the bottom picture, you can see that there is a very dramatic appearance where the Schwalbe line has detached into the anterior chamber. And some of these patients can have systemic anomalies that's called axonfeld rigor syndrome, for example, periumbilical skin tags, and then you can have some dental anomalies. Then Peters anomaly, again, it is characterized by a central corneal opacity present at birth. It can vary from mild or to moderate, where there are iridocorneal adhesions, to severe, where there are corneolenticular adhesions as well. And the incidence of glaucoma in both axonfeld rigor anomaly and Peters anomaly is as high as 50%, so you need to follow up these patients lifelong. Then what is the diagnosis? This is aniridia. You have very hypoplastic iris. The term is a misnomer because iris is not totally absent, but it's a grossly hypoplastic iris. And if you do a gonioscopy, you will find that there's a rudimentary iris stump. And you remember, aniridia is not only restricted to the iris. There are other problems, like there is foveal and optic nerve hypoplasia. There is keratopathy due to Limber stem cell deficiency, and these children have cataract and glaucoma, and the incidence of glaucoma is as high as 50 to 70%. Another important thing you should remember is when you find a child with aniridia, please send the child for a systemic workup to a pediatrician, because many of these children will have a condition which is known as Wilms tumor or nephroblastoma, and you need to follow up these children with renal ultrasound till the age of 6 years. Then spot diagnosis, this is Sturge-Weber syndrome. You know, there's skin involvement, brain involvement, and eye involvement. In the eyes, you can have, apart from this glaucoma, you can have choroidal hemangioma, and that can cause a problem while you do glaucoma filtration surgery, because there can be suprachoroidal hemorrhage. So these children can be managed either by trabeculectomy. The top child we manage with a trabeculectomy, and the bottom child we manage with a pediatric Ahmed glaucoma valve, and both are doing well. Now we come to the main diagnosis for these developmental glaucomas, that is a primary congenital glaucoma. So the primary congenital glaucoma is the most common form of developmental glaucoma, and it is due to isolated maldevelopment of the trabecular meshwork, also called isolated trabecular dysgenesis. It can be newborn onset, infantile onset, or late onset. And the rate of the condition is more common in areas where there is a consanguineous marriage is common, particularly in southern part of India. It's bilateral 70% of cases, but maybe asymmetric. The genetics is very important in this condition, and it's usually inherited as autosomal recessive. 3 loci have been identified: GLCA 3A, 3B, and 3C, and GLCA 3A is the major locus, and it codes for the gene called CYP1B1. Now, regarding the pathophysiology, it was initially thought there's a membrane, pretrabecular membrane called the Barcal membrane, which is actually obstructing the aqueous, but subsequent studies have not established this membrane, and the current conception is that there's a developmental arrest of tissues at the 3rd trimester of gestation. This causes thick and compacted trabecular sheets of trabecular tissue, and this prevents the posterior sliding of the iris. The important thing is to diagnose these children early, because initially the corneal edema is an epithelial edema, and if you do a surgery at the correct point of time, some of these children or most of these children will recover. But subsequently there is permanent stromal scarring, and then the child will not get back vision. And you have to beware of the mimickers. So do not rely only on the IOP for diagnosis, because intraocular pressure in children can be tricky. The aims of evaluation are, number one, to confirm the diagnosis and to rule out space-occupying lesions. Now, regarding the history, the common points that you have to inquire are: what is the age of onset of the symptoms? The typical symptoms are the epiphora, photophobia, and blepharospasm, and hazy corneas. And remember that in most Western textbooks, it is written that the classical triad is epiphora, photophobia, and blepharospasm. That the types of congenital glaucoma that we see in India and the Indian subcontinent, many of these children will present with large eyeball size and hazy eyes, because they present late, and the condition may be more severe than that found in the Western countries. And rarely some of these children can present with acute eye drops. Parents may complain that yesterday the child was okay, suddenly today morning we found that the cornea has gone hazy. So the visual assessment has to be done by age-appropriate methods, and the most important tool for diagnosis is the examination under anesthesia. And during the examination under anesthesia, the most important things that you will do are that you will measure the corneal diameter, you will check the intraocular pressure, and for this you need the Perkins applanation tonometer, and also you will look at the optic nerve and the fundus. Regarding the choice of the anesthetic agents, remember that all anesthetic and sedative effects lower the intraocular pressure, excepting the mnemonic KBC, that is ketamine, benzodiazepine, and chloral hydrate. Sevoflurane is the most commonly used inhaled agent, and the important thing to do is that as soon as the child becomes sedated, you have to record the IOP before the child is intubated, or else you will get false recordings. The IOP, as we have discussed, is to be measured by the Perkins applanation tonometer most commonly, but the eye care tonometer is also a good alternative. The corneal haze you have to grade regarding as to what are the posterior structures that you can see, whether you can view the pupillary margin or the iris details or the fundus details. And the corneal diameter, as I have been stressing, is very important. You have to measure the corneal diameter, and you have to check the horizontal visible corneal diameter, because superiorly the conjunctival encroachment into the cornea may be variable. It is the white to white horizontal visible corneal diameter, and the values we have already discussed. The corneal striae are very important. These are called the hub striae. They are more typically horizontal, centrally near or across the visual axis. And an important differential diagnosis are the striae that you get due to forceps injury. They are, on the other hand, they are vertical, unilateral, and central, and associated with periocular bruising. Now you have to do a gonioscopy, and the characteristic findings that you'll see in gonioscopy is that it's a flat and high iris insertion and absence of an angle recess. The gonioscopy can be done by a cope lens or by surgical lens like the Swan-Jacob gonio lens. So regarding the fundus, a cup disc ratio of more than 0.3 in an infant or more than 0.5 in an older child is suspicious. There is, you know, that there can be striking reversal of cupping. Some of these children, when the surgery is successful, the cupping may reverse. And you should exclude other findings like a choroidal hemangioma in a Sturge-Weber syndrome or a pigmentary retinopathy in rubella. Now, pachymetry is not that important in children as in adults. Axial length, as I said, that absolute value may not be important, but increase in axial length on sequential examination is a sensitive indicator of glaucoma progression. B-scan is very important. If you suspect any child who is having a congenital glaucoma, the corneal view is hazy and you cannot evaluate the posterior segment clinically, please advise an USG B-scan. In the bottom figure, you can see this child, this unfortunate child where the diagnosis was missed. Initially, it was thought to be a congenital glaucoma, but actually the child had retinoblastoma. So there are mimickers of primary angle closure glaucoma, the primary congenital glaucoma that you should remember. Watering can also be due to congenital nasolacrimal duct obstruction, and these are the differential diagnosis of a hazy cornea at birth. So these are the mnemonic is stumped. You can go through it: sclerocornea, tears in the Basements membrane, ulcer, metabolic corneal opacities, posterior corneal defect, endothelial dystrophy, and dermoid. So these are the diagnoses. What is this? This is sclerocornea. This is Peters anomaly. This is the Basements folds due to the ruptures due to the birth trauma. This is congenital hereditary endothelial dystrophy. This is the corneal opacity that is associated with the Hurler syndrome. Now, regarding the medical treatment, it is primarily a surgical disease, but initially for buying time, you can use drugs like the carbonic anhydrase inhibitors and timolol. Never use brimonidine, which is contraindicated in children less than 6 years of age because of the risk of apnea. Surgery is the mainstay of treatment, and the first surgery has the best chance for success, and it is preferably to be performed by a trained surgeon with adequate surgical skill and experience and a safe anesthetic setup. Now, just a few points regarding the surgery. The angle surgery, that is the goniotomy and the trabeculotomy, is a procedure for choice for primary congenital glaucoma. And if the cornea is clear, you can do goniotomy. If the cornea is not clear, like so many of the children that we see, then you have to do a trabeculotomy or a combined trabeculotomy and trabeculectomy. So these are the surgical options. The goniotomy was introduced by Barkan, trabeculotomy ab externo by Burian, then trabeculectomy introduced by Cairns. Combined trabeculotomy and trabeculectomy, the first report was published by Eugene Moll, and it was popularized by in India by Dr. N.N. Sood at RP Center, and subsequently Dr. Anil Mandar at Elvir Prasad Eye Institute. And now we have the 360-degree trabeculotomy, endoscopic goniotomy, and for recalcitrant cases, you have the tube shunt implants and the cyclodestruction. Now, a few points about goniotomy. The cornea has to be clear, otherwise goniotomy cannot be done, and the position of the surgeon is important, like the microscope is tilted about 35 degrees towards the surgeon, and the patient's head is tilted about 35 degrees away from the surgeon, so as to bring the angle into view. And we need surgical gonio lens like a Swan-Jacob gonio lens, and it's performed with a MVR blade or a 23, 24 or 25 gauge needle. And you have to engage the angle gently with the blade tip halfway between the root of the iris and the Scholby line. And successful goniotomy is indicated by the anteriorly inserted peripheral iris falling back with widening of the angle. Now, this is the conventional trabeculotomy. I will show a short video, so I will not discuss further. This is trabeculectomy. Trabeculectomy, as you know, is the surgery of choice for adult glaucomas, but for pediatric glaucomas, we have to resort to them when the angle surgery has failed. The combined trabeculotomy and trabeculectomy is the most popular surgery that is performed in India, and it targets two pathologies. One is the trabeculotomy for the angle anomaly, and trabeculectomy for the pathology in the collector channels and beyond. So this is a short video of the video.
Debashish, you have 5 minutes.
Yeah. Okay, sorry. So you can see this is a child with primary congenital glaucoma, and you have to take a clear corneal traction suture, and you have to dissect the conjunctiva. I need to fast forward this. Can you have this? Right. So now this triangular scleral flap is made, just as you do in a trabeculectomy. Okay, I'll just go a little forward. So this is the most important step. You have to localize the Schlemm's canal, and remember where white meets blue, Schlemm's canal waits for you. So this is a scratch incision. You have to open the inner wall of the Schlemm's canal, and then you have to introduce the trabeculotome inside this Schlemm's canal. So once you have identified the anatomy, yes, so this is the Herm's trabeculotome that you have to insert, and you have to be very careful so as you're entering the right plane. There should not be any resistance. So once you have reached the right plane, you have to introduce the trabeculotome, and then you have to sweep it across the anterior chamber, and you have to do it on two sides so that you can rupture about 90 to 120 degree of the Schlemm's canal. And after that, you have to do a trabeculectomy like you do in an adult case. You have to remove a block of the deep scleral tissue, and you have to apply sutures. And you have to close the conjunctiva. Okay, so that is a conventional trabeculotomy. And then presently, there is a circumferential trabeculotomy that has come up, so where you can target about 360 degrees of the Schlemm's canal. And then you have the glaucoma drainage devices in conditions where the angle surgery results are not very good. And this is a new technique. I would just conclude with this. So this is a new technique which is popularized by Dr. Anil Mandal. This is called illuminated microcatheter passage assisted circumferential trabeculotomy and trabeculectomy, or the IMPACT. So I will again show a short video of this.
The aim of this video is to demonstrate an improved surgical procedure for advanced primary congenital glaucoma. A limbus-based conjunctival flap was raised and the dissection was done in the episcleral plane. Hemostasis was meticulously maintained with the help of bipolar underwater cautery. A 1/2 thickness triangular scleral incision was delineated and the scleral flap was then dissected towards the limbus using a number 15 Bard-Parker blade. A 2 by 2 millimeter trabeculectomy block was outlined without penetrating the anterior chamber. A central radial incision was then made just behind the junction of the bluish-grey band and the white band to incise the external wall of the Schlemm's canal. A drop of viscoelastic material and the device was advanced into the canal.
So you can see the illuminated microcatheter being introduced. You can see the light. So this microcatheter will traverse 360 degrees of the Schlemm's canal, and by the light you can judge whether it's going in the proper plane.
When it emerged from the distal end of the canal and was pulled out a little bit. Both the exposed ends of the catheter were pulled in opposite directions using a tangential force like a purse string. Thus,
okay, so this is followed by a conventional trabeculectomy as usual. Thank you.
Thank you, Dr. Debashish, for that wonderful video session. And now we move on to the next talk by Dr. Vinita Ramnani on neovascular glaucoma. Because of the constraints of time and the time exceeded in previous session, and in order to ensure that you all don't go into a state of hypoglycemic shocks, we first complete all the presentations and then we can have question answers or discussions over lunch. Dr. Vinita is a well-known glaucoma surgeon coming from Bhopal and a good friend of mine too.
Thank you, Dr. Purvi. At the outset, I would like to thank Dr. Santosh Sonawar for the opportunity, and I will be presenting on neovascular glaucoma. If in exam, theory, or anything, if you want to remember, you should divide the topic into various headings. So when you have a smaller headings, probably you can remember the topic very well. So these are the subheads under which I am going to talk about neovascular glaucoma. So the introduction is like a definition of anything. So it's a neovascular glaucoma is a severe form of a secondary glaucoma, which is characterized by the fibrovascular proliferation into the anterior chamber, where the delay in the diagnosis or treatment can result into the blindness, and we have to treat the raised intraocular pressure as well as the cause of the disease. So Coates first time described this rubeosis in 1906, and in a patient with central retinal vein occlusion, where he coined the term hemorrhagic glaucoma, thrombotic glaucoma, congestive glaucoma, rubeotic glaucoma, even 100 days glaucoma. And the Weiss was one which proposed the term neovascular glaucoma. So these are the small questions which are written at the down, where it can be asked in your exams or theories, your practical exams. Etiology, it is multifactorial. There are various lot of local as well as systemic factors which are responsible for the disease. It could be a ocular vascular disease, out of which the diabetes, ischemic CRVO, CRAO, BRVO, and BRAO is responsible. There could be chronic long-standing inflammations like uveitis or retinal detachment. It could be neoplasms like malignant melanoma or retinoblastoma. Beside diabetes, it can occur in sickle cell disease or SLE, and in extravascular disorder, the carotid obstruction and giant cell arteritis is the common cause, which is responsible for neovascular glaucoma. And many surgeries like cataract surgery, the vitrectomy, the retinal detachment surgeries, or even the YAG laser can give rise to neovascularization and ROP, PHPV, Eales disease, and Coats disease. What is the presenting symptom? What is the three major causes? If somebody asks you, it is diabetic retinopathy, ischemic CRVO, and ocular ischemic syndrome. These are the major three causes for the neovascular glaucoma. In diabetes, it is mainly in PDR, where there is an advanced diabetic retinopathy, which leads to the ischemia, and because of the ischemia, there is a neovascularization in the anterior chamber. Also, there is a risk of involvement of other eye too. So, why diabetic retinopathy patients developed an NVG? It could be because of the long-standing diabetes associated with long-standing hypertension, hypercholesterolemia, or the patient underwent a cataract surgery and developed NVG because of the posterior capsular rent, or it could be a vitrectomy patient or a long-standing RD patient in a diabetes. And why this neovascularization occurs? Because the posterior capsule is a barrier for these angiogenic factors which are released because of the ischemia created in the posterior chamber. So they come forward and they create a new vessels at the angle as well as at the iris. Same happens in the ischemic CRVO. So in non-ischemic CRVO, the neovascularization is not there unless it is associated with the diabetes or anterior segment ischemia. So one should remember that it is only the ischemic CRVO which is responsible for neovascular glaucoma. So we need to differentiate what is ischemic and what is non-ischemic CRVO. So we can see in this table that ischemic variety is less common. It is only 20 to 25%, which has very poor visual acuity. There is an REPD and the visual field defects present, and there are a lot of hemorrhages. And you can see non-perfused areas in FFA, that ischemic areas, and it shows in ERG changes and prognosis is poor. While in case of non-ischemic variety, it is very common, 80%, but the visual acuity is good. There is no RAPD, there are no visual field defects, the hemorrhages are less, angiography doesn't show any ischemic areas, ERG is normal and prognosis is good. So one should able to differentiate the ischemic CRVOs from non-ischemic CRVOs. And usually it happens in 100 days. That's why it is called as a 100-day glaucoma also. In ocular ischemic syndrome, basically it is the carotid artery ligation or obstruction which is giving rise the anterior segment ischemia, which is responsible for neovascularization. So the prevalence overall NTG out of all secondary glaucomas is 9 to 17%. And in general, if we talk about the pathogenesis, if somebody asks you what is the real factor which is responsible for neovascularization, is retinal hypoxia, which is leading to angiogenic factor release and ultimately the development of a new vessels. What is the presenting symptom? It is pain, redness, associated with the diminution of vision. So the diminution of vision comes first, followed by pain and redness. But sometimes it could be a sudden pain along with the redness and reduced vision together. So this is the typical presentation when one should think that gradually the asymptomatic disease, the patient may not realize the diminution of the vision and suddenly come with the pain, redness, and diminution of vision. But definitely if you ask for a history, they will have a history delineating that they have a reduced vision also. They might go underwent a cataract surgery which is complicated with a PCR, maybe a phakic or post-vitrectomy patients. When you do an examination, they look like a normal if there is a gradual rise in intraocular pressure. But if there is a sudden rise of an intraocular pressure, it behaves like an acute angle glaucoma patient. So all our acute angle glaucoma patients, they come with a lid edema, conjunctival congestion, corneal haze. But then the differentiating feature between the angle closer glaucoma and neovascularization is the presence of new vessels. And you have to look for these new vessels inside, because of the edema, you may not be able to see it. So where you will see it, it is at the pupillary margin. So there will be a very fine, delicate tuft which is seen at the pupillary margin. Like in the first photograph, it is being marked by arrow because it is not obviously visible. In second photograph, you can see there are obviously visible neovascularizations. Anterior chamber might show a reaction because there is a damage to the blood aqueous barrier, so there could be flare, hyphema present. The pupil is dilated, but you should look for the pupillary margin, new vessels. There could be ectropy on UV. This picture shows that there is a fibrous membrane at the angle which is pulling the posterior layer of the iris and making it seen anteriorly. So normally this brown layer is not at the margin, it is behind. So now you can see that on the anterior surface of the iris, which is called as an ectropy on UV. And RAPD is a clear-cut demarcation for the ischemic CRVO. Lens, depending upon whether it is cataractous, aphakic or pseudophakic. Fundus, depending upon the pathology, could be CRVO, could be diabetic retinopathy, and there could be a raised intraocular pressure. So you can see that what is the first sign? It is the tuft at the pupillary margin, which leaks on FFA. So you can do an FFA and see these small vessels, lacy vessels leaking at the pupillary rim. And there is 12% chances that there could be only angle neovascularization. There may not be iris neovascularization. So you have to see the angle by gonioscopy. And investigations beside good gonioscopy and slit lamp, you can do an angiogram, ICG, Humphrey Visual Field Analyzer, OCT to look out for the edema, and OCTA. OCTA is coming up because it is a non-invasive procedure and it can give you a larger area of the retina, which is ischemic, can be seen, and you can see even the vessels, the amount of the vessels, the regression of the vessels on treatment. So it's a good non-invasive investigative equipment which gives you the detailing. And you should be able to differentiate whether it is a dilating iris vessels or it is the new vessels. So you can see in the diagram that new vessels, which are usually located, as I told you, at the pupillary margins, they are irregular, thin, arborizing, and they leak on angiogram, and they cross the blood aqueous barrier, while the normal blood vessels, they are thick, they are present in the stroma on the deeper layers, and they are regular, they are tortuous, radial, but non-fenestrated, therefore they doesn't leak on an angiogram. So you can see in the picture, the upper picture is showing a normal vessel in the stroma, and the lower picture, which is being marked, showing in vessels. And why they leak? Because there are fenestrations. But there are any other condition in which the vessels leak on angiogram? Yes, in exfoliation syndrome and Fuchs heterochromic iridocyclitis. So that could be a differential. And beside ocular investigations, you can do a systemic investigation depending upon the cause, maybe for hypertension, diabetes, and many other things. So this is the varied presentation of neovascular glaucoma, and you should have a clue for each and everything because there are so many stages. It can start with pre-rubeotic stage where there is no iris vessels. It can go into rubeotic stage where there are vessels but no high pressure. Open angle glaucoma where there is a high pressure. And angle closer glaucoma is the one which is very typically seen with the corneal edema, and last is the burnt out stage. So in the earlier stages, we should look for an gonioscopy to find out whether there are new vessels or not. And then Vand give the classification of these vessels. Stage 1 at the pupillary margin, then at collet colorate, then at the angle, and then they crosses the scleral spur. So NVI and NVG both can go together, but angle vascularization is very important because it crosses the scleral spur. So you can differentiate the blood in the Schlemm's canal and the new vessels that they crosses the scleral spur. So this is the theory, which is retinal hypoxia, release of angiogenic factor, vasodilatation, and vasoinhibitory factors. And there could be loss of vision because of the ischemia to the optic nerve. So there could be an optic atrophy. Differential diagnosis, as I said you, angle closure glaucoma, but then it could be uveitic glaucoma because of the presence of the keratic precipitate, could be ICE syndrome, because it can also give rise to the ectropy on UV and corneal decompensation, old trauma, or Fuchs heterochromic iridocyclitis. So these things you should keep in mind, and management is basically control intraocular pressure. Once you control the intraocular pressure, you have to look into the cause of neovascularization and treat it and prevent its recurrence, and if the patient is not improving symptomatically, get the relief by pain. So these are the protocols, that medical, laser, and surgical. Medically, you can use anti-glaucoma drugs, but then what are the two drugs which are contraindicated in neovascular glaucoma? Prostaglandin and myotics, yes. And anti-inflammatory drugs and anti-VEGF gaining a very good importance in neovascular glaucoma. Then we can have a lasers, which could be PRP or cyclophotocoagulation or goniophotcoagulation. And surgically, we can do TRAB, AGV, and if there is a pain, we can give retrobulbar alcohol and can go for an enucleation. And anti-VEGF are very important agent for treating neovascularization. They can given intravitreally, they can given into the anterior chamber to treat the NVI, and within 48 hours, these new blood vessels, they go away. Then you can go ahead with PRP, or you can go ahead with the trabeculectomy. They will not give any hemorrhages, otherwise there could be a chance of hypema and complication. But if you do only anti-VEGF, they will recur again. So you have to do a PRP. Once you do a PRP, you will prevent the recurrence of the disease, and you will just avoid these ischemic changes which are there in the retina, and thereby you will avoid the release of these VEGF which are there in the retina, and that's why the new vessels, they regress. But then it takes 3 to 4 weeks for the new vessels to regress once you do a PRP. There are various methods. The detail you have to remember in the laser section. You can do the laser on the gonioscope also by doing a gonio-photocoagulation by argon laser. As I told you, you can do a trabeculectomy depending upon the severity of the glaucoma, but then mitomycin C has to be used because these secondary glaucomas are very intractable glaucomas. So they you may have a failure of trabeculectomy. So you can use mitomycin C or 5-fluorouracil, or better to use an AGVs. But if there is a pain and the pressure is not being controlled and the patient is no PL, you can go for a cyclodestructive procedure, which is cyclophotocoagulation, or could be a diode laser or argon laser or YAG laser for the treatment of the ciliary body, which could be endoscopic also. So these are the various parameters which are being given in your books. Probably you have to remember all these parameters, that what is the duration, what is the power, and how do you proceed for doing these type of different lasers. And as I told you, you can go for a cryo also, which is easily available because we all have a cycloprobes for the retina, but the retina cycloprobes are little smaller. They are 2.5 millimeters, and the glaucoma cycloprobes are bigger. They are 3.5 millimeters, because you have to put at the ciliary body area, and you have to thaw that particular area. And it is very useful in cases of hazy media where there is no PL and you cannot do PRP, you cannot do any other thing, so you have to cycloablate. Newer treatments, they are not very promising, but then with the advent of anti-VEGF, the NVG has a better prognosis in comparison to the previous, when we were not having VEGF in our armamentarium, the prognosis was very poor, but nowadays with the PRP, with anti-VEGF, and with glaucoma shunts, we can preserve the vision for these poor eyes. And if they are not being treated in time, you can have complications in the form of a bullous keratopathy, complete synachial closure, and very intractable glaucoma, which is very painful, where you have to give either alcohol retrobulbar or can go for an enucleation to relieve the pain. So to conclude, the NVG is a secondary glaucoma, which is blinding, and it requires a multidisciplinary approach because the cause is lying in the retina. So you have to have a retina colleague with you, or either you have to be doing that PRP or anti-VEGF treatment yourself. And if you diagnose timely, if you treat timely, probably you can save the vision. And you should remember the 3 major factors that if you are treating a diabetic retinopathy patient, you have to alarm them regarding this NVG if they are not being promptly treated. The second common is ischemic CRVO and then ocular ischemic syndrome. So with this, I will come to one case of mine, which is 72 years male, hypertensive, non-diabetic, not having any ischemic heart disease, presented with a gradual diminution of vision in both the eyes, which was more marked in right eye. And now he had sudden severe pain and redness in right eye. And this was his anterior segment examination and the fundus photo. You can see that dilated pupil, there is a cataract, there is a neovascularization at the pupillary margin. So it's a very clear-cut diagnosis. You can differentiate between right and left, that there is a glaucoma. You can see the PI in the other eye also. So that means must be a primary angle closure glaucoma before. And the vision was very poor, 660. You can draw the gonioscopy like this, that you are seeing NVA here. And this is the picture, but the BP was very high. So after the control of blood pressure, you can take this patient for further investigation. So this is the fundus finding, where there are many hemorrhages. The other eye looks glaucomatous cupping, you have read in the morning. And this is the angiogram. This is the OCT, which is showing the macular edema, and this is the OCT RFNL showing RFNL loss. The same HVF, which is correlating, you have read today morning that you have a correlating disc field changes and OCT changes. And after a good control of glaucoma, anti-VEGF, PRP laser, he has improved drastically. You can see in post-PRP angiogram, there are no leaks now. And I did a combined surgery for this patient later on, which I skipped. And this is the post-op photograph. So this patient is doing well, having a 6/9 vision. So you can salvage NVG patients if you treat them in time. Because I have a time, I can show my video of combined cataract plus glaucoma surgery in this patient. So after cutting the conjunctiva, which is fornix based, you can put 3.5 into 5 millimeter triangular or rectangular, depending upon individual choice, 1/3 to 2/3 thickness, and then you enter through the same and complete the phaco procedure through the same triangular inner cut which you have created. And so rather than going through the cornea or the sclera, you are going through that scleral flap, and then through the scleral flap, you can complete the procedure. This is called as a single site phacotrabeculectomy, which is a combined phacotrabeculectomy. You can use it with the mitomycin C also, or without mitomycin C. So once you have done the surgery, you can implant a lens, and after implanting the lens, you have to cut the inner window. So this is the lens implantation, and after that, this is the triangular flap. So you have to now cut the inner block and then suture. So this is the cutting of the inner window, and this is the suturing. So you have to put 3 scleral sutures with a tenno nylon, and with the tenno vicryl, you can put the sutures, and this is the result. Thank you so much. Thank you for the opportunity and patience listening.
Thank you, Dr. Vinita. You practically leaked the question paper with all those questions and answers given. Now I invite Dr. Manoj Chandra Mathur sir for his presentation and talk on medical management of glaucoma.
Yeah. So, good afternoon. We shall be discussing about the medical management in glaucoma. So, the magnitude of the problem, we know that about 12 million people are affected and 1.2 million people are blind from the disease. What is important for us to know is that 90% of the cases in India remain undiagnosed compared to 50% in the developed world, even that is high. And on the converse, what we should also know that 50% are overdiagnosed. On one side of the spectrum, 90% is undiagnosed, so we need to be aware about the disease, and on the other side, we don't need to overtreat them. What is the definition of glaucoma? It is a family of ocular diseases characterized by progressive optic neuropathy and visual field loss. So what does it mean? There is a progressive retinal ganglion cell loss that results in gradual optic disc cupping. This is the structural damage or the defect that is taking place, and these, when they are associated with the visual field deficits, form the structural and functional correlation, and this constitutes the diagnosis of glaucoma. And mind you, elevated intraocular pressure no longer is included in the definition, though that might be the only modifiable risk factor as far as the prognosis is concerned. So, in glaucoma, we know that there are two types: in-angle closure glaucoma, acute and chronic, and then comes the primary open-angle glaucoma. For acute angle closure glaucoma, you need to first do osmotic reduction of aqueous vitreous volume by giving mannitol or oral glycerol. Then comes the aqueous formation reduction through carbonic anhydrase inhibitors. Then can you open the closed angle by pilocarpine or by corneal indentation in an acute angle attack, and then supportive treatment like NSAIDs, injectable antiemetics, and adequate hydration. The chronic angle closure glaucoma, we need to use pilocarpine to physically open up the angle, and then plan YAG API, especially if it is an appositional closure, and rest of the treatment will be as for POAG. What is the treatment philosophy for medical management of glaucoma? The aim is to prevent nerve fiber loss, to prevent any further visual field deterioration, and most important, to retain the quality of life for the patient. If you see this curve here, as the age advances, there is a normal physiological loss. If you detect the disease at this point, if you don't treat the patient goes into the realm of blindness by this curve. The aim of treatment is not to skew this curve this way, but to make this curve run parallel to the normal physiological loss. So over a period of time, even with medical management, there will be some loss of RGCs, but this RGC loss should be minimal so as to run parallel to the normal physiological loss. And visual field deterioration, whatever is lost is lost. The aim of medical management is to retain or to maintain a similar visual field for the rest of the life for the patient. The quality of life, it is very hard to quantify, but for the patient it is the most important, isn't it? The diagnosis, very diagnosis generates anxiety. Mind you, the patient will never sleep peacefully for the rest of his or her life. Functional loss to the disease, inconvenience of treatment, very simple for us to prescribe 6 drops per day. Is it possible for us to use for the rest of our lives? Side effects of the treatment, exposure to the preservatives, and last but not the least, in our setup, the cost of the treatment. So what we can do, we can only modify and control the intraocular pressure. Can we afford some sort of a neuroprotection or vasoperfusion for the patient? Is to be looked after. It is still experimental and not conclusively proved. So what we have to do is, we have to come to a conclusion what can be the normal advisable target pressure for that patient. If not a target pressure, what can be the target range? And this depends on the glaucoma damage, the amount of damage, glaucomatous damage that you have diagnosed at the time of diagnosis. If it is early, you can afford to have a little bit of extra, maintain the patient on a little higher target pressure. Or if it is advanced, you have to go aggressively. The life expectancy, if the expectancy is short, you can possibly have a little higher intraocular pressure. The untreated IOP, that is at the baseline, if the IOP is more, you can afford to have a little more by percentage of reduction, you can aim for a little higher target pressure. If it is the damage has detected, the baseline intraocular pressure is low, especially like in NTG, you need to bring down the pressure further. And additional risk factors. What can be the additional risk factors? Like family history, prolonged use of steroids, trauma, diabetes, hypertension, thyroid disorders, etc., etc. If the risk factors, depending on the number of risk factors, you need to calibrate the intraocular pressure, desired intraocular pressure, which can be a target intraocular pressure or a target intraocular range. And over a period of time, when you're following up this patient, you need to further revise the target range of the intraocular pressure depending on the amount of rate of progression. So, can we give some sort of a neuroprotection, or can we give some sort of vasoprotection, that is by increased microcirculation or vasodilatation or increased perfusion to the optic disc, is still under experimental stages, but promising results are coming, and probably in the near future we may have conclusive evidence regarding this. So, what we have discussed till now, the ultimate goal of medical management boils down to this one particular statement: preservation of visual function adequate to the individual needs with minimal or no side effects for the expected lifetime of the patient without any disruption of his/her normal activities at a sustainable cost. Isn't it? One statement, what we have discussed over the last 10 slides boils down to this one parameter. So this is the treatment philosophy. This is the one statement that should guide us in the management of our patients. And the next point comes, you should understand what is the mechanism of action of anti-glaucoma medication. Basically, they act at the inflow, that is at the ciliary body, by reducing the amount of aqueous, and then there can be a facilitation of outflow from the two pathways, basically a uvascular pathway and to a certain extent through the trabecular outflow pathway. So, if you see the drugs available with us as on today, I'm not going into what are the possible things, what are the coming things, whatever are available as of now, the prostamides, the alpha-2 agonists, the cholinergics, the prostaglandins, and the ROCK inhibitors, they act by facilitating the outflow channels either through the uvascular outflow or the trabecular meshwork. And what are the inflow reductors available for us as of now? The alpha agonists, they act both at inflow, reducing the production of aqueous as well as facilitating the outflow facility, the beta-1 blockers and the carbonic anhydrase inhibitors. So, whenever you are assessing an anti-glaucoma medication, the way to go are these three parameters. What is the ability to modify the intraocular pressure? That means, what is its efficacy of an anti-glaucoma medication? Number two, what are the possible side effects of that particular medication, both ocular as well as systemic? And last but not the three, any bonus that that particular anti-glaucoma medication is able to offer us by way of neuroprotection or vasoperfusion or any remarks or remarkable things. So based on these parameters, let us evaluate the drugs that are available. The good old pilocarpine, it is a cholinergic, it acts by meiosis, physical stretch on the ciliary body, but the side effect profile of this drug causes visual disturbances by way of meiosis, and brow ache is very common for the patient, but it is a cheaper treatment. We cannot write off this drug in our glaucoma medication in certain situations. This drug plays a major role and is very efficacy. The efficacy is standard 3+. The invention of beta blockers, timolol in the 1970s, followed by levobunolol and betaxolol, they revolutionized the management of glaucoma. How do they act? They act by reducing the production of aqueous, the side effect profile, basically pulmonary and cardiac profile, and it causes depression, tiredness, and possible bradycardia for the patients. Timolol, over a period of time, causes vasoconstriction, causes tachyphylaxis over a period of 4 to 4.5 years. Betaxolol is supposed to may not cause vasoconstriction, and it is supposed to maintain the visual field better. The efficacy is similar, and mind you, still whatever new anti-glaucoma medication is coming or on the anvil, they compare their efficacy. I am as good as timolol, I am equal to timolol, I am better than timolol. So timolol still remains the gold standard of medical management. Then came the alpha-2 agonists. They act by dual mechanism by reducing the production of aqueous, as well as increasing the UV scleral outflow. Hyperemia and drowsiness are a common side effect profile of this medication. Do they afford some sort of neuroprotection? Yes, animal studies have demonstrated, but they have done that experiment with 2% brimonidine, but what brimonidine we use is 0.2 or 0.1%. So established in the animal model, but yet to be conclusively proved, they are as good as timolol. Then came the carbonic anhydrase inhibitors. They act by reduction of production of aqueous. And whenever we are thinking of combining a medication, we need to combine medication which has a different mechanism of action. But here, there are two molecules, both reduce the production of aqueous, but mind you, we can combine them because the mechanism of action by reducing is a different pathway. The carbonic anhydrase, they inhibits by formation, inhibiting the formation of bicarbonate ions. So there's accumulation of water and carbon dioxide. Accumulation of carbon dioxide causes vasoperfusion, vasodilatation, and this is supposed to be vasoprotective. So then came the PG analogs, the latanoprost. They act basically through the UV scleral outflow, the side effect profile, the uveitis, CME, and iris pigmentation or the eyelash growth, and this increases the perfusion also, and it also has a vascular perfusion benefit to the patient. Efficacy is better than timolol. Then the same thing for travoprost, they claimed endurance, that over 72 hours the action lasts and a better diurnal control. Then the bimatoprost, similar profile, they profess that about 35% of the outflow is also through the trabecular meshwork, and the efficacy is almost same. The tafluprost, the new kid on the block of prostaglandin analogs, they claim that the hyperemia with this molecule is minimal, but the effect is as good for all the 4 PG analogs. And now the current things, the ROCK inhibitors or the ROCK kinase inhibitors, they act by increasing the UV scleral outflow, but chiefly through the trabecular outflow, and they also cause reduction in the episcleral venous pressure, this thus reducing the intraocular pressure. A major concern for us as of now is hyperemia, corneal verticillata in some cases. They also profess anti-inflammatory properties, and they protect the endothelial cells, prevent CME also. They basically open up the trabecular meshwork and have potent effect. Now, the challenges in glaucoma, whenever you are thinking about medical management, is non-adherence may contribute, suboptimal IOP control for the patients. As I said, it is very difficult for you to follow the regime to the point, 6 drops a day for the rest of your life. Unfixed combination of topical therapy increase the schedule complexity and make affect adherence from the patient, and medication washout as a risk of with installation of multiple medications. So the way to go is fixed combination products. They have multiple advantages, that more convenience, dosing with a single bottle can improve the compliance and diminish risk of washout, and then limits the patient lifetime exposure to potentially damaging preservatives. So fixed combination medications are a way to go whenever possible. And all the studies indicate the advantages of fixed combination medication. What we need to understand and analyze is the fixed combination, what is its efficacy, what about its tolerability, how is the patient able to tolerate that medication, and is the patient able to adhere to the prescribed medication as you have planned for the patient. So the choice of fixed combinations, if you see the list here, all through pilocarpine timolol, dorzolamide timolol, brimonidine timolol, latanoprost, different types of things with timolol, or travoprost with timolol, and bimatoprost with timolol. All the combinations here were with timolol, but now if the patient is not able or to tolerate timolol, or if timolol is contraindicated for the patient, the introduction of a fixed combination of brinzolamide and brimonidine opened up the new vistas for us, and then of late the ROCK kinase inhibitors, also a combination with ripasudil, has again given us an opportunity to use FDCs in a better way. How much, like with brinzolamide and brimonidine combination, you can achieve maximum medication with all the 4 molecules in just 3 drops in 2 bottles, whereas with RI, with So all the medication, 5 molecules can be used in about 4 to 5 drops in about 3 bottles a day. This is not a mathematical calculation. You cannot say that I'm using 5 molecules. Every patient has a different way of reacting to a particular drug molecule. You have to assess each and every patient and what is the best for the patient. Limited number of bottles, limited number of drops, you need to go that way. And though whenever you are treating a patient, always start with monotherapy, whichever drug you are starting. Then if the drug is acting and the target pressure is reached, you can continue. If the drug is acting, target pressure is not reached, you need to add a drug. If the drug is not acting, in such case, you need to switch the drug. If you see this thing, the first choice monotherapy, it is effective and verify the tolerability. Target pressure is reached, then you need to continue and target IOP is maintained. Periodically, you need to verify these endpoints. Whenever for review, what is important is look out for the quality of life for the patient, the visual field, the optic disc, and the IOP. Then if it is not effective, we need to switch. If it is effective but target pressure is not reached, in such situations, you need to add a drug, and even then with maximum medication, if it is not, the pressure is not under control, then you have other options. So let us wind up with just 3 clinical situations. A 32-year-old software engineer, this was the patient, my patient, with established structural and functional correlation. He was on treatment with brimonidine and timolol. Baseline IOP recorded was 25 millimeters, not too high. Presently, I recorded 19 open angles, both eye inferiotemporal RNFL thinning with superior arcuate separation. Spending most of the time reading about glaucoma on the net, wife complained about their quality of life. He came for second opinion to me. What do we do? Pressure is only 25. So in this way, baseline pressure is only 25. Why are we using 3 molecules for a 32-year-old? And what is the molecule that we are using that is impacting the quality of life? Timolol. Suitably modify the treatment. Counsel the couple. After 3 months they came, they were happy. So such sort of things. Individualize the treatment. 82-year-old female with established structural and functional correlation, moderate POAG on treatment with brimonidine, timolol, and bimatoprost. 3 molecules. The baseline was only 24. Present pressure is 12. Do we need this kind of an aggressive IOP for an 82-year-old? When we discuss target pressure, I showed you the curve. Since I'm running short of time, just 3 minutes to go. Yeah, we can have a quick interaction. What would you like to do? Can we reduce the medication for this patient, and can we aim to have a increased target pressure for this pressure or patient or a target range? Yes, we can. We can reduce one of the molecules and improve the compliance of the patient and let the patient live peacefully and happy. Clinical situation 3, 46-year-old male, fair complexion with established unilateral glaucoma. He was on treatment with PG analogs. Baseline was 18 only in one eye and present 14. What would you advise? Are we justified in continuing a prostaglandin analog for this patient? Because we know the side effect profile of prostaglandin discoloration. Okay? So we can switch this medication to a better medication. If 24-year-old pregnant female with early glaucoma, what would you advise? What could have been ideal? What should be your line of management now? Actually, prenatal counseling is important for these girls. Ideally, what would have been ideal is counsel the patient appropriately, put off the drugs for that patient, preferably. Do a PI if there is a probable occlusion. Do whatever you can. If you have if you have laser procedures, you can. But in case the patient has already conceived, how to go about it? We need to understand the 5 categories of medications, the A, B, C, D, and X. Most of the glaucoma medications fall in category B. Like, what does category B medications mean? They have a varying or contradictory human or animal data. For example, a drug may be graded as class B if animal studies showed some harm, but human studies indicated safety, or vice versa. And category C, basically, they have described the medicine which shows side effects in animal models or where there is inadequate animal or human studies available. So the best option for us is in the first trimester, for a pregnant lady, the only option that you have is possibly brimonidine. Mind you, brimonidine cannot be used in the last trimester or during labor because it has the ability to cross the blood-brain barrier and cause apnea and depression to the patient. Second trimester, probably beta blocker and brimonidine with caution. The third trimester and postpartum, possibly dorzolamide. Dorzolamide should never be used in the first trimester because of its teratogenic properties. Brimonidine is contraindicated in labor and lactation because they have a potency to reach the blood-brain barrier. So with this, this was a brief half-an-hour presentation, our overview of medical management of glaucoma. With that, I conclude my presentation. Thank you all for your patient hearing. Now it is my privilege to invite my co-chair, Dr. Puri Bhagat. She is a professor and head of Glaucoma M&J Regional Institute, BJMC, Ahmedabad, and she has done an international fellowship in medical education. So over to you, Puri. She will be speaking next.
So first of all, I would like to thank Team CFS, especially Dr. Honavar, Dr. Rashmin Gandhi, and importantly, Dr. Rolika Bansal for the meticulous coordination that she has been doing from the beginning till the end, I suppose. So I'll be talking on lasers in glaucoma. Lasers in glaucoma can basically be defined as those which are used for diagnostic purposes and those which are used for therapeutic purposes. In diagnostic, of course, we know that is scanning laser polarimetry, which is popularly known as the GDX. Then we have the confocal tomography, that is known as the HRT, and of course the optical coherence tomography. But for the purpose of this presentation, and since the diagnostics have practically been quite dealt with, I'll be focusing on the therapeutic aspects. So the therapeutic laser procedures for glaucoma are those which are used for angle closure glaucoma, that is the laser PI, iridoplasty, those which can be used for open angle glaucoma, that is laser trabeculoplasty, which can be argon, which can be selective, or which can be micropulse, and those which are used for refractory glaucomas, mainly the cyclophotocoagulation group, which can be transscleral, which can be endoscopic, and which can be micropulse. We can also have laser therapeutic procedures post-trabeculectomy, wherein you can do laser suturolysis and bleb remodeling, and there are certain miscellaneous procedures like gonioplasty or iridoplasty, laser iridotomy, goniopuncture, and goniophotoccoagulation. The different formats in which all of these can be asked to you in exams, it can be a whole long essay question where you can be asked to write about lasers in glaucoma, or any of the laser procedures can come as an individual short question. And of course, anything can be asked in cases, in table vivas, and any of the laser instruments, equipments, especially the lenses. The Abraham lens is very commonly kept on the tables. So you're supposed to know about that also, and that can also form a part of your table discussion. And of course, the information that is shared will be useful to you in your practice after you become ophthalmologists. Talking of lasers, the headings under which you are supposed to write ideally is, of course, the first thing that should be is describe the laser, which laser, what is its wavelength, and what are the accessories that go with it, the principle or the mechanism of action, indications and contraindications, the procedure with a special focus on what are the settings and precautions to be taken, the prior preparations before the actual laser procedure is done, the post-op care, complications. Sometimes many lasers, as I already mentioned in the classification, they are used for a single type of a procedure. So you may have to write their merits and demerits and compare and contrast between them. And finally, if you have come across any important studies and you are aware of them, then you can also mention the different studies related to that laser procedure. So let's go through these procedures one by one. The most commonly which is performed is the laser iridotomy. The principle we know, it is mainly used to counteract this relative or absolute pupillary block that we know of, which happens in primary angle closure glaucoma disease. So here, basically, the aqueous, it collects in the posterior chamber, and it causes a iris Bombay type of a configuration, and which closes the access to the angle. So what an iridotomy does is, it creates a direct communication between the PC and the AC, and it allows free access of the aqueous through this channel. So what are the indications? In angle closure suspect, it should always be done in fellow eyes of established angle closure or angle closure glaucoma, those who cannot come for regular follow-up, those who have a posterior segment pathology and need frequent pupillary dilatation, one-eyed patients, and those who have a family history of primary angle closure or angle closure glaucoma. In cases of PAC and PACG, they always have to be done, and so also in acute attacks of primary angle closure. In secondary angle closure, when it leads to iris bombay, again a PI has to be done, and there are miscellaneous conditions when PI is not the ultimate definitive treatment, but it has to be done to control the pupillary block component. For example, in Plateau iris syndrome, the first treatment you do is do a PI, so that you remove the pupillary block component. And then what remains, if still the IOP is not under control, the angles are not opening, then you may go for iridoplasty or put the patient on pilocarpine, or may go for other medical treatment or surgery. Same way in phacomorphic glaucoma. Of course, the definitive treatment will be lens extraction, right? But before that, to control the IOP, to allow a safer lensectomy and to relieve the component of pupillary block, you do a prior PI. Same for aqueous misdirection, nanophthalmos. In pigment dispersion syndrome, why do we do a PI? What is the basic pathophysiology? Reverse pupillary block, right? So in iris bombay, what happens? It's a convex type of a configuration. And in pigment dispersion, it's a concave type of a configuration. So again, here the pressure differential will be different. It will be more in the AC than in the PC. So by doing an iridotomy, you are neutralizing that pressure gradient, making the iris configuration from concave to flat, and thereby controlling the friction that happens between the iris and the lens, and controlling the pigment dispersion that happens. In ACIOLs, nowadays, lot of retro-iris fixation lenses are done, so a PI here is must. The older versions of phakic IOLs did not have that holes within the IOL, so a PI was mandatory. Now the phakic IOLs, they are coming with the holes which prevent pupillary block, so it's okay not to do in those cases. And sometimes before a laser trabeculoplasty, when the angle recess is very narrow and you are not able to see the meshwork, then you can do a prior PI. Contraindications, obviously anywhere where there is a non-pupillary block mechanism, like drug-induced secondary angle closure, which is the most common drug which is known for this, which causes primary angle closure, bilateral, topiramate, right? So there could be antipsychotics, even sulfonamide, salbutamol, and many other drugs. They cause a ciliocoroidal effusion and thereby cause angle closure. So here it is just withdrawal of the drugs, steroids and cycloplegics that you need. You don't need to go for a PI. Same way where other mechanisms for angle closure are there, like neovascular glaucoma, where there is an anterior pulling type of a pathophysiology, IC syndrome. So here you don't need to go for a PI. Rather, you should not do a PI in these cases. Coming to the procedure, of course, as in any other procedure that you do, explanation and consent is very, very important, especially when you are planning to do a PI in cases of advanced damage and when split fixation is there. If the patient is on anticoagulants, they have to be omitted in consultation with the physician, and the IOP should be as low as possible. So the patient will be comfortable, the cornea will be clearer, and you will be able to do the PI in a single setting if the iris is also not edematous. Pilocarpine 2% has to be instilled before you do a PI. So keep instilling every 10 to 15 minutes till the pupil is miotic and non-responsive. So what will pilocarpine do? Stretch the pupil. So what? So it will make the iris taut and it will allow easy penetration of the laser. So lesser energy will be required. You can do it in a single setting with a single perforation. Topical apraclonidine or brimonidine may be used before the procedure to prevent the post-laser spikes. And of course, the patient seated comfortably and the eye anesthetized with a topical anesthetic drug. This is again a very common question which is asked, and the lens is always almost put on the tables. So this is the Abraham contact lens which is used for doing the iridotomy. It is applied with the use of a coupling fluid or gel. It's basically a 10 millimeter diameter button which is placed on the lens. It's a plano-convex 66 diopter. Whatever its uses, it allows magnification. It acts as a speculum keeping the eye open. It helps to stabilize the eye, preventing any fine movements which may happen. It concentrates the energy, so lesser amount of energy will be used. It acts as a heat sink, so damage to the surrounding structures, damage to the cornea can be prevented. And if there is bleeding, you can just press on the eye with the lens so that it can have a tamponade effect. What will be your site of PI? It is almost always the superior PI that you do, and you have to see that your iridotomy should be adequately covered by the upper lid. 11 and to 1 o'clock to avoid foveal irradiation so that you don't damage the fovea, and also for this, you can ask the patient to slightly look nasally or temporarily and not directly look ahead. Always avoid the 12 o'clock position. Why? Air bubble is there, right? So if that air bubble is present and it rises up to 12 o'clock, it will not allow the further laser penetration. That air bubble will block that iridotomy site. So you will not be able to continue at the same site. Always to be done in the peripheral third of the iris. So not extreme periphery, because then it may, those small tags of iris which form, they may cause small peripheral anterior synechia, and not medially because it may damage the lens. So peripheral third is like when the lens just starts bowing down, at that point you should do. And an area of thin iris. So wherever it is thin, wherever you see an iris atrophic patch, or wherever you see a crypt, there it has to be done. But if in the superior area, if there is silicone oil or any of the gases are there, then you have to do an inferior PI, which is known as the Japanese iridotomy. Depending on the iris thickness, the energy could be from 3 to 9 millijoules. If you use excessive energy, it may damage the lens or it may damage the cornea. And if you just keep on doing with a lesser amount of energy, it will just cause iris chafing and chipping of the superficial iris tissue, and there will be unnecessary inflammation and pigment dispersion. The focus, it should always be set first at 0 so that you focus on the iris surface, and then slightly posteriorly offset so that it converges posteriorly on the iris stroma. Because of this posterior offset, the plasma wave which is created from the laser shot, it will come anteriorly, that is anteriorly towards you, so it will help to penetrate the anterior iris surface also. And the endpoint, as you can see, it's a sudden gush of aqueous, release of pigment granules, and which is known as the smoke sign or the waterfall sign. Simultaneously, there will be deepening of the AC, you can see retroillumination, and even the lens capsule can be visible. What is the ideal size of the PI? It is usually 200 to 500 microns. And subjectively speaking, it should be just adequate that when the iris recoils, the effect of pilocarpine goes, and when you dilate the pupil, that iridotomy should not close. So that much size should be there. And if you need to enlarge, always enlarge it laterally, because if you enlarge it same direction radially, again it may tend to close down. So always enlarge laterally. If the iris is very thick and you're not able to do it in one sitting, you may have to do it in multiple sittings, maybe 2 or maybe even more. So you first make a small iris atrophic patch, try to thin out as much as possible, and then in a subsequent sitting, you may repeat it. Or you can do an iridoplasty, and then in a subsequent sitting, you can do a YAG iridotomy. Post-laser, you give steroids, IOP lowering, monitor the IOP, and most important is repeat the gonioscopy. Sometimes you are not sure on the slit lamp whether the PI is patent or not because of a dense arcus, or it may be just too small. So in these cases, you may resort to any of the imaging techniques, UBM or ASOCT, and confirm the patency of the iridotomy. And if the IOP is not coming down, angles are not opening, that means something beyond the pupillary block is into play. What are the complications that can occur? The complications mainly occur either because the energy that you have used is too high, your procedure or focusing is not proper. The most common is disturbing visual symptoms which occur due to aberrations. So as you can see in this image, the iridotomy is actually transacted by the position of the upper lid. It is just bifurcating there. So that will lead to lots of visual symptoms. But these, just with counseling and over time, the patients get adapted with that and they may go away. IOP elevation, damage to cornea, damage to lens, hyphema, aqueous misdirection, uveitis, and if there is significant amount of inflammation or your iridotomy is too small, then it can get closed. These are just a small set of questions that can be associated with iridotomy either in theory or practicals. But this is not an all-inclusive list. So if your examiner asks you something beyond that, don't blame me. कि पूर्वी मैडम ने iFocus में तो इतना ही बोला था. Okay. Then we move on to laser trabeculoplasty. So laser trabeculoplasty can act through 3 different ways. One is the mechanical theory, wherein there is stretching of the trabecular meshwork beams, which directly allows the aqueous outflow. Then there is a biological theory, wherein there is an inflammatory cascade and reaction which happens. Macrophages are released, which remove the trabecular meshwork pigment granules and open the meshwork. And there is a cell division theory, wherein the loss of endothelial cells in the beams, it stimulates other endothelial cells, which migrate, divide, and form a different type of an extracellular matrix, which further facilitates the outflow. Among this, the earlier one which was used was argon laser trabeculoplasty. It's a continuous wave of an LTP, but it causes coagulative necrosis, thermal damage, and fibrosis. And that is why it is no more used. What is more popular is SLT, that is selective laser trabeculoplasty. It's basically a frequency doubled Q-switched Nd:YAG laser, 532 nanometers, and it's a pulse wave type of a laser. Because it is pulse wave, and as the name suggests, it is selective, so it causes very selective photothermolysis, targeting only the pigmented trabecular meshwork cells, and thereby it avoids all collateral damage. Also, the parameters are too short to generate any heat. So practically, it delivers just 1% of the energy which is used by ALT. Therefore, fewer complications, and it is a repeatable procedure. So what are the indications? One of my indications would be that patient sir had mentioned, where the wife is complaining of the quality of life. So that open angle glaucoma case, I would rather go for an SLT rather than put the patient on drops. So those are the indications. POAG, where the IOP is uncontrolled, despite maximum medical treatment, patient is not compliant, not tolerating, surgery is not possible, or patient is unwilling for surgery, and as a first line also. Ocular hypertension cases, combined mechanism glaucoma, where you have already done the PI is patent, but the outflow channels are irreversibly damaged, and you have to put the patient on drops. So rather than putting the patient on drops, you can do an SLT, provided the meshwork is visible. Glaucoma in pregnancy, again another indication for SLT, because we have lots of contraindications for drugs, surgery cannot be done. And secondary cases like steroid-induced pseudophakic, pseudoexfoliation, and pigmentary. Contraindications, one of course would be where the trabecular meshwork is not visible, and complicated glaucomas like those with uveitis, NVG, trauma, and angle dysgenesis. Normal tension glaucoma is not a contraindication per se, but the efficacy of SLT in these cases is very less compared to other glaucomas. So it is not actually desired as a first-line treatment for these cases. And the patient has already undergone an ALT and it's a densely pigmented meshwork, then probably that the meshwork has already been damaged significantly. So SLT in these cases would not be effective. Procedure, again the same prior preparations would be there, explain, consent, xylocaine, patient seated comfortably. The lens that we use here is the SLT lens known as the Latina lens. It has a button like this, which is like a gonioscopy mirror. You insert the lens just like a gonioscopy, you visualize the angle, and you have to focus the laser beam on the meshwork. The spot size here is 400 microns, 0.3 nanoseconds duration, which is fixed. The energy change, can be from 0.2 to 1.7 millijoules according to the density of the pigment. And what will be your endpoint? You keep increasing the energy till you see the formation of these small air bubbles, which are known as champagne type of an air bubbles. And you decrease the energy by 0.1 millijoule, 0.2, just below that. So that would be your endpoint. And you can treat 180 or 360 degree depending on the requirement. Post-laser treatment would be the same as for any other lasers. Complications also are same. You know, in pharmacology in second year, whenever the examiner asks, what are the side effects of so-and-so drug? What do you say? Nausea, vomiting, diarrhea, right? NVD. So similarly for laser, you can remember the 3 I's. Okay, one is IOP spike, Second eye is inflammation, and third eye is inadvertent damage to the surrounding structures. Okay, so you can remember the three eyes and you can write the complications. So depending on what procedure has been done and what are the neighboring structures, those can be damaged. But overall, SLT is a relatively safe procedure. It usually causes about 20 to 25% of IOP lowering, but requires several weeks to months for the complete effect to be seen. And the efficacy is determined by the type of glaucoma, the TM pigmentation, the pre-op medications. It is said that more the number of medications are there, the TM would already be influenced and modified by those drugs. So then SLT will have a lesser effect. And if the pre-op IOP is higher, then SLT will have a higher efficacy. In the same category, you have the micropulse laser trabeculoplasty. It is similar to SLT, but here the wavelengths are, it's either could be a diode, which was used earlier, and now it is the double frequency YAG, 532 or 577. So just like you have in phaco, you have continuous wave and a pulse wave. Similarly, here the energy is delivered in pulses. That is, there is an on period and an off period. So that off period, it allows the trabecular meshwork to cool down. So the damage is less. The spot size is 300 microns. Because it is in a micropulsing fashion, no significant damage or complications are there. And for the same reason, it is beneficial in patients who have dense pigmentation of the meshwork and who are at a risk of higher IOP spikes. These are the common questions which can come with respect to laser trabeculoplasty. And since here you have three different types of lasers, argon, selective, and micropulse, you can write about their merits and comparison also. Coming to iridoplasty, again, any of the three lasers can be used, argon, diode, or double frequency YAG. The basic principle here is that you apply burns to the iris periphery to contract and pull the iris from the angles and thereby opening up the angles. So these small burns that you see, they are the iridoplasty burns. Indications, after a PI, if still it's a case of Plateau iris syndrome, that peripheral roll of iris is still there, then you do an iridoplasty. If a PI cannot be done for any reason, then you may do an iridoplasty and open the angles. Or a PI is done, it is patent, but there is still residual appositional closure, or along with goniosyneculasis. Contraindications, of course, when you are not able to visualize the iris for any reason. Procedure here, again, pilocarpine is used to stretch the iris as much as possible. The parameters are mentioned, 500, 0.5 to 0.7 seconds duration, and starting from an energy of 240 milliwatts. You can do it in three fashions, either using an Abraham gonio lens, or using a gonio lens, Abraham lens, or using a gonio lens, in which case it is known as gonioplasty, or you can use it directly without use of any lens. Complications, again, similar. Its efficacy and long-term success is controversial. And because iridoplasty is most commonly done in cases of Plateau iris, any discussion which relates around iridoplasty may ultimately end up in discussion and questions about Plateau iris. Coming to laser photocoagulation, earlier it was used for refractory glaucoma, but now with the advent of use of endoscopic photocoagulation, it is now also used in patients who have good visual potential and even in pediatric glaucomas. It is more effective and better tolerated than cyclocryo. It causes lesser hypotony, lesser pain, and lesser chances of phthisis. The lasers used earlier were ruby and krypton. Now argon, Nd:YAG, or diode are used. Three routes are there, transscleral, transpupillary, or intraocular. And it can be done either in contact fashion using probes, or it can be used on the slit lamp using a non-contact delivery system. Because you are treating directly on the ciliary processes, you have to see that you don't cause any perforations and fistulas. So you have to avoid areas where there are blebs, thin sclera, tubes are present. And because of the presence of long posterior ciliary nerves, always avoid the 3 and 9 o'clock positions. Otherwise, they will cause intense pain. What is the mechanism of action of cyclophotocoagulation? Of course, as the name suggests, you are basically photocoagulating the ciliary body. So direct destruction of the ciliary epithelium, inflammation, ciliary body ischemia because of damage to the vessels, all of them can lead to decreased aqueous production. And there can be increased outflow either transsclerally or uveoscleral or through the conventional pathway also. What is commonly used is a transscleral, wherein a diode laser is used, 810 nanometers. A G probe is used. This is known as a G probe. And the end point here is when you hear a pop sound. That means the ciliary process has actually got atrophied. And you can treat 180 or 360 degrees as required. Nd:YAG can also be used. And complications mainly, apart from the others, are if you use excessive energy or treat excessively, then it can lead to hypotonia, phthisis. But this is still less common compared to cyclocryo. You also have micropulse diode laser, wherein the principle is same. The energy is delivered in micropulses. There is an on period and off period, and so it is safer. But these probes that come for micropulsing, they are quite expensive. So that has to be kept in mind. And we have the popular ECP nowadays, endocyclophotocoagulation, wherein it's a complete standalone unit. You have the 810 nanometers diode laser, and you have a video monitor wherein you can actually visualize the ciliary processes. It has different fiber gauges and different probes, a curved probe and a straight probe. And because you can actually visualize the ciliary body and treat them directly, it is not only used for refractory cases, but also it can be combined with other intraocular surgeries like cataract extraction, MIGS, or VR surgeries. So here the endpoint will be whitening and shrinkage of the ciliary processes. And again here you can treat as much as required, 180, 270, or 360. Because it is done under direct visualization, the complications are less, but again here the cost of the entire equipment is a concern. This is the differentiation between transscleral and endoscopic. Endoscopic, because it is intraocular, you can do it under topical or intracameral like you do other surgeries. But for the same reason, it has always to be done under aseptic conditions in the OT. The incision would be required, whereas transscleral, you don't need any incision, and the probes required for both are different. Again here, the group of questions can be common, and because there are multiple lasers, you need to compare and contrast. In malignant glaucoma, you can use Nd:YAG for iridotomy, wherein after you do a PI, you also do a rupture of the posterior capsule and of the anterior hyaloid phase. So that aqueous which is sequestered posteriorly, it can gain direct access through the anterior vitreous, through the capsule, and into the anterior chamber. Because this is mainly related to malignant glaucoma, you can also be asked questions, and you will need to describe a little bit about malignant glaucoma as well. After trabeculectomy, sometimes the filtration is not adequate and the scleral flap sutures are either too many or they are too tight. Then you may want to rupture or break one of the sutures after trabeculectomy to enhance the filtration. So this you can do via laser, either few days or few weeks after, or if you have used an antimetabolite, which is very common nowadays, 2 to 3 weeks later. And the lasers could be again a frequency doubled Nd:YAG, argon, or diode. So what is done here, any of the lenses are used. This is the Hoskin lens, blue menthol lens, Mandelkern lens, or rich lens for nylon suture removal. So you place it over the area of scleral flap. You slightly compress it so as to blanch the conjunctival vessels. So the sutures will be very easily visible. And then you apply the laser so that suture breaks open. After breakage, because it has been a sealed opening, so what you have to do is apply a little bit of digital pressure, either by the side of the flap or as you would do a digital massage on the inferior lid, so that the aqueous gushes out or slowly comes out through that opening that you have created. Always remember that only to lyse one suture at a time. Don't break all the sutures at one go, otherwise there will be flat AC, overfiltration, and even malignant glaucoma can occur. And the parameters will depend on what laser you have used and what is the thickness of the bleb wall. Sometimes when you do a gonioscopy, you can find over the ostium there is either iris tissue there, or a membrane is there, or a vitreous tag may be there. So you can rupture this using an argon or an Nd:YAG, which is known as a laser goniopuncture. So that will help to open up that closed ostium. Then there can be laser management of overhanging blebs. Like overfiltering and overhanging blebs, they are huge and large blebs encroaching sideways and encroaching on the cornea, on the limbus, and they may cause hypotony, dysesthesia, and cosmetic concerns. So to avoid surgical interventions like bleb excision or bleb revision and sutures, you can go for a laser procedure. Here the argon laser is used. So basically you paint the bleb surface with gentian violet, which helps for early, easy laser penetration. And then with very low parameters, you just char the superficial surface of that bleb. You just coagulate it so that it shrinks down. Sometimes if this is not possible, using an Nd:YAG laser, you can create a small rupture in the bleb, which will allow the aqueous to flow out, and then you can coagulate the area and close it. Sometimes new vessels are present in your surgical wounds, which can be gonio-photocoagulated using argon laser. These cases are quite common, uveitic cases, and you keep on doing multiple PIs time after time, but they keep closing down because of the intense inflammation. And even centrally, if you see, there are 360-degree posterior synechia. So you can use argon or Nd:YAG to break these synechia very carefully, not damaging the lens. So you do this synechia lysis, and you can see that the pupil is now dilated. So even if your PI is not functional, you can allow the aqueous to flow through the normal channel through the pupillary area. So you can use laser in uveitic glaucoma cases also. You can use it for cyclodialysis cleft, argon to close, and Nd:YAG to open the clefts. And of course, now in the era of femto and excimer, sorry for that smell check, this grammar didn't help me here. So you can use it for creation of trap Phillips, you can create suprachoroidal fistulas, thin membranes can be excised, but of course this is still into research, and it is still not a common practice to use femto and excimer for glaucoma surgeries. But this is something which is coming up gradually. So whenever you talk of lasers or write about lasers, you have to write about the principle and mechanism of action, the procedure, focus on the settings and how to adapt those settings to the procedures, and most importantly, how to avoid the complications. Thank you.
Thank you, Dr. Purvi, for that wonderful exposition about lasers. Now it is my privilege to invite Dr. Venkatesh Rangaraj. He shall be speaking on advanced surgical techniques in glaucoma as a video-assisted skills transfer. Dr. Venkatesh Rangaraj is the Chief Medical Officer of Arvind Eye Hospital, Pondicherry. He is an excellent clinical teacher and a researcher. Welcome, Dr. Rangaraj, for your presentation.
Thank you. It's so nice to see enthusiastic residents. I see a smile there. Huh? I know it gets tired after some time, listening to glaucoma. Some of my colleagues say glaucoma is an enigma not only for the patients but also the treating physicians. Many times we don't really understand what is glaucoma, what do we really do for glaucoma. But I take this opportunity to thank the team iFocus, which we have been closely associated for several years. I think it's one of the best PG teaching programs, and I'm sure I want you to relax for the next 30 minutes, okay? Because when we were residents, we had only one glaucoma surgery to read, which was trabeculectomy. Nothing else. It's so unfortunate that now you will have to know several other techniques. There will be a little bit of repetition between what I say and also my colleague, Dr. Vanitha, who is going to follow me. But the thing is, you have to understand something about at least some of the basics of some of the advances which is happening in glaucoma surgery, because it's going to be, again, in recent advanced question or in your viva, somebody will ask you, how does an eye stent work, or an hydrus work, or a GART work? So it will be nice to really understand, but once you go back, look into more details in YouTube or some textbooks where it's already there, well written up, I'm sure you'll understand more. So basically, I think Dr. Sweta is going to cover a little later after the lunch. We all know still the gold standard is trabeculectomy. In a developing world setting where people are well trained to do this, still it is the gold standard. But it's not very rewarding. That's why a lot of people don't do glaucoma surgery. No, there are so many, it takes longer time, there are a lot of post-operative care, you have to see them for 3 months, 6 months, and a lot of unexpected outcomes, like some of the images which you see there on the screen. Anytime it can happen, no? From early post-op to late post-op, no? You are late, and then the patient still comes back after several years. And because of this, there is a kind of negative marketing. So we have been always looking at something which is highly safe, which is less invasive than what a trap does, and also where there is kind of a quick recovery. No, that is where everyone is aiming at. And cataract has seen so much of advances, and soon we are seeing that in glaucoma also. So this is an interesting Mediclaim data, which was published way back in 2012, and 22 you can think it would have still changed. It was done by my good friend Pradeep Ramalu and Johns Hopkins, where you can see the trabeculectomy, no, significantly reducing. That is because of, one is lasers, which is increasing, and also the aqueous shunts, no, which was significantly increasing, especially Barwell and Ahmed glaucoma valve. And Express and eye stunts were coming up, but now I think they are looking at the data again. It's still not published. I just had a look to see it's totally different now. No, there is no more trabeculectomies now. So we all understand that one size does not fit all, right? So that's where you may have to tailor a glaucoma surgery. We were not tailoring, you know, for whatever reason we are doing either a trab or a combined, or in advanced glaucoma, a tube shunt surgery. But now there are several options, keeping in mind the age of the patient, the kind of glaucoma, his progression, his advanced stages. You can tailor a glaucoma surgery, and that's where I'm going to touch upon. So any question, I'm sure you all know, it's always good to classify, you know. So even if there is something on advances in glaucoma surgery, you can classify something like this, you know, get into something which improves the subconjunctival filtration, something which can improve the Schlemm's canal outflow, or through the suprachoroidal space, or you go for a destruction, which was briefly covered in the previous talk on laser also. So basically, you can get into these two compartments. One is outflow procedures, and the other is procedures which are targeting the inflow. So when you talk about outflow procedures, no, you have these three drainage which you are targeting. One is the subconjunctival drainage, which normally you know very well. Trabeculectomy does that. And then now there is a lot of focus on trabecular drainage. You know, how can we directly get into the Schlemm's canal? And then the third, suprachoroid, which is again a space which people have worked on, but not many of those devices are very successful. So when you talk about subconjunctival drainage, I think trabeculectomy, as I said, is the gold standard, but there are a lot of modifications which has happened over trabeculectomy, and one is the use of a shunt also, called an express shunt. And then we look at briefly about the oral lab aqueous drainage implant. It's similar to Barwell, but because we now have that implant in India, it's widely used now. And then a little bit of non-penetrating deep sclerectomy, and how we can even do that with a carbon dioxide laser. So these are some of the techniques which are at present available. Some have been practiced actively, some may not be practiced actively, but these are the options available even in a setting like in India. Okay, so this is what you see in an express shunt. No? Basically, you use a 25 or a 26 gauge needle at the area where you have the gray zone between the clear cornea and the sclera. And then this comes with a beveled tip and a spur and a backplate. No, the backplate goes and stays. Basically, instead of punching, what you're using is you're using a inert material. It's a stainless steel material. And now you can see I'm just checking the patency of the express shunt with a stain there, and then you see the leakage. So it's just similar to trab. You have to do the same flap, but instead of doing the punch with your Kelly sponge, you are putting this express implant, no, which is not only express, it is also expensive. Somewhere at some point, no, people saw the results were not any different. Again, you have to use mitomycin, again you have to do needling, again you have to do suturolysis and all that. Sometimes you can express also can become a nice samadhi, like some of the samadhis you have here. So we'll go to the other one, no, which is, I'm sure nobody is covering, so I thought I'll show you how we do a tube shunt surgery. No, because tubes and valves are there for several years now, bare world almost there for 20 plus years, and then we had an opportunity to develop from Orolab, the Orolab aqueous drainage implant, which is similar to bare world. I have no financial interest, and now it has been extensively used. Now, a couple of weeks back, I was in Ghana, where they had RD and they were comfortably doing. I think it's because of the availability people are now using. So that's the plate, and you can see this is a ripcord suture, which basically helps you to kind of tune the surgery after, and then you have to place your vicryl, a 7/0 vicryl, to tighten and make sure the tube is not patent. So this is very important because this is not a valve, so you need some time for it to naturally lyse the suture and work. And then you identify the two muscles. Here it's the superior and the lateral rectus because it's placed supratemporally. You can even do supranasally if you want. There is a failed bleb in this case. And then you keep the wings of the RD under the muscle and then make sure that ripcord is not affected. This is just a suture to keep your conjunctiva away so that you can comfortably suture the plate and the tube also onto the sclera. And then you fix the plate nicely with nylon sutures. And then you anchor it, and then we are just reassuring one more vicryl suture just to make sure the tube is not patent. And this vicryl suture gives way after 5 to 6 weeks, and then it opens up the tube for it to work. So this is a technique which we learned from Dr. Paul Pomberg, who was a pioneer in tube, just to make a kind of, not a straight entry, but a kind of a skewed entry to one side. So basically this helps you to have a longer tube for future in case if you want to replace the tube. And this is a technique which is now widely done. It's a long track created by a 23 gauge needle. Some of these gauge you have to keep remembering, 25, 23, 26. So this is a 23 gauge needle. So you make a long scleral track and then you enter parallel to the iris. Make sure it's not very close to the endothelium because the tube close to the endothelium can damage your endothelium. And then you have to carefully measure how much you want and then you trim the tube. And then you have to gently insert the tube. There are inserters, you can use your McPherson's forceps, and you insert the tube and make sure it's nicely there. If there is any issue very close to endothelium, you have to reconsider in a different place. And that's why you keep the straight area open. And tomorrow, if there is somewhere where you want to do it again, also you can do it. And then this is the supramid suture, which is cut and then kept under it. So in case if you want to have a good pressure control, you can always go in and remove this suture. So this is like a suturolysis in your trabeculectomy. It can work, or you allow it to absorb. And then finally, we have to meticulously close the conjunctiva. Like at any glaucoma surgery, conjunctival closure is very important. So this is how you do a tube surgery. The same way you do a valve also, Ahmed glaucoma valve. So deep sclerectomy, this is like a modification which came again a couple of decades back, but not very popular because it really needs a very good skill to do that deep scleral flap. So there is a superficial flap and there is a deep scleral flap. This is so deep where you are just on top of the Schlemm's canal. If you penetrate, then it becomes a penetrating surgery. So it's a non-penetrating, but it needs such a very good skill to do the deep flap. And also you need very good instruments, like the one you're seeing here is a diamond knife which is being used. And then when you dissect off the deep flap, it's called the deep sclerectomy. And you can enhance this by doing a viscocanalostomy. You can inject visco into the Schlemm's canal on either side, or if you have facilities, you can do canaloplasty. Now we have done this technique, but it's kind of time consuming, but it's got very good results. But again, it needs a meticulous skills to do this. And there is a catheter called iScience catheter. Similar to the catheter, people have used sutures, phyoprolin sutures. I'll show you how it is done internally. But this is an iScience catheter. So basically, it's like your interventional radiology or cardiology. Now we are getting into interventional ophthalmology, where you can really intervene into the Schlemm's canal. So you see the light source there, which is blinking. So that shows that you are into the Schlemm's canal, 360 degree. So you take the catheter all around, and then you put your suture, which is going to stay inside, tightening the Schlemm's canal. So this helps you to kind of make sure that you are working 360 degrees to enhance the outflow. So some procedures have helped us to do a certain clock hours. Some procedures have helped us almost 180 degrees. But now here it's almost 360 degree. No, you keep a proline suture inside, no, which is a 9O or a 10O proline, which is going to stay inside the Schlemm's canal. And then you have to finally remove the catheter, it is just facilitating your surgery there. And you can inject visco also through the catheter. No, you can visco dilate 360 degree Schlemm's canal when you're doing it. And then finally you tighten the suture. This tightening can also be seen under an ASOCT to see how tight it is and how Schlemm's canal is opened up and how the outflow channels are helping to improve. And then finally you close the scleral flap. So this is basically to show you how a non-penetrating deep sclerectomy, and then it can be added to a form of viscocannulostomy or a cannuloplasty like this. So this is very difficult. So I had an opportunity to do something called a carbon dioxide laser. Now we had this for some years with us, and again, the machine maintenance, the cost of paper case cost and all that didn't work out. So we no more do this, but it was a very nice way of doing the deep sclerectomy much more safely. And again, keep this in mind. See, this is a combined surgery, where phacoemulsification is done, and after the lens is implanted, you come back to your original flap. So it's nice to construct the flap before when you have a nice tight chamber. And this is the important zone, this gray zone between the clear cornea and the white sclera. So there are a couple of laser burns. First goes on to the scleral blood, just to deepen that particular area so that you have a area where the aqueous can pool. And then you can change the dimension of the laser. So basically, carbon dioxide laser does not work when there is fluid. So once you open up the canal and there is aqueous coming out, the laser will stop working. That is how it really helps you without penetrating and making it into a penetrating surgery. Than doing manually, this laser really helps us to open up the Schlemm's canal nicely. And through this, again, you can see the aqueous percolating. You can do a viscocannulostomy here, or you can even try to put a suture inside into the Schlemm's canal, which works. And it may not work in all cases, but it works. So this is basically a non-penetrating deep sclerectomy using a carbon dioxide laser. So from subconjunctival, I think we'll go to some ab interna subconjunctival. Now, this is still not available. Now, Allergan has been saying for quite some time that we'll be having this, but still not available. So it's called a Zen implant. It's a very soft, flexible, collagen-driven gelatin implant. And what basically does is again increases the outflow. But here, people tried it from doing it externally, but now there is an internal way of doing, and we know, we are not still doing this, so this video courtesy is from my good friend Aik Ahmed. And you can see he's just putting a gonio lens to visualize the trabecular meshwork, and this is a 27 gauge needle, I think so, 27 or 28. So you have to go, and then you have to make a scleral track, and you have to come out into the subconjunctival space again. So in this particular needle, there is the implant also, the gel implant is there, and then you gently push that implant. So it's like they say 3, 2, 1. So 3 millimeters is in the subconjunctival space, 2 it's in the sclera, and 1 millimeter into the cornea. So it needs a very meticulous training, a lot of practice in wet lab, even for a very good surgeon, because I've seen people doing it, and immediately you can see the bleb here happening. So this is actually a bleb-related surgery. It's called a Zen implant, but it can be done through an ab interno, and it enhances the subconjunctival outflow. Okay, let's now get into the most important part, the trabecular drainage, which is getting really popular. So there are things which I'm sure you're going to listen to this again also in the next talk, but basically eye stents are now available in India. So there are 2 stents now which is available. So this is the regular eye stent which you see, and now we have the eye stent inject now, which is much more easier to do. And mostly these are for mild to moderate glaucoma, where they are on one medication, not much advanced damage to their nerves. You can consider this, But the important part is to practice intraoperative gonioscopy. Like what you see here, it's very important to see the angle, see the trabecular meshwork. So this is something like putting a Venflon from the skin, subcutaneous, and then getting into the vein. So it's a practice, it comes. So it comes with the injector. So you see the model here, the snorkel, and this is into the anterior chamber. This goes into the Schlemm's canal. And then you have to inject it. And then once you are very comfortable that it's inside, then you release the prong, which opens up. And then you get it out. So immediately you can see the blood from Schlemm's canal. So that's a nice sign that there is a blood which is already in the Schlemm's canal, which is coming out immediately. And you can see how the stunt is. Same way now, it's become much more simpler. You can put any number of stents you want all around. But again, cost is important. It works. 1, 2 better than 1, 3 better than even 2. But we don't know exactly where to put. But we still try, and it works for some cases. So this is a very simple inject. It goes with the injector, and then you press on the trabecular. There is a pinch sign you see, and once you pinch, you inject it, and then it goes inside. This part goes inside, and the other part outside, and the center part will be in the canal. So this basically, again, increases your drainage from the anterior chamber directly into the Schlemm's canal. So this is how we are looking at trabecular outflow. So you can see the stent here, and post-operatively you can visualize, and we have to make sure the iris doesn't go and block it, so some post-operative care is very important. So the other way of doing it is using a blade, which is designed by one of my good friend, Malik Kahook, from, again, US. So you can see the angle visualization is so important, like how you see in this video. So basically, this blade is like this. It's a dual blade, very smartly designed with a central cavity. So it shaves off your trabecular meshwork, and it opens up the cleft and makes a direct entry into the Schlemm's canal. So you do it for a couple of clock hours on either side. So you're working from temporal to nasal. So 2 clock hours on either side if you do, maybe 4 to 5 clock hours. And you can see that hemorrhage now. I mean, it's not basically hemorrhage. It's the blood from Schlemm's canal, which is coming out. So you have to clear that and see. So high molecular weight viscoelastic is very important. You have to push it back and see how the nice cleft is there. So this works. Again, mild to moderate glaucoma. There are several publications. I don't want to get into that. But the other thing which we routinely do is called the gonioscopy-assisted transluminal trabeculotomy. We learned this from Davinder Grover, who is in Texas. Very innovative surgeon. After his MPH, he wanted to do something innovative for glaucoma. Then he said, I should develop something which can be done in any part of the world, even in a developing country setting. And that's how we came up with this phyoproline suture, which you can smartly now, instead of doing an outside canaloplasty, which I have done, it's not very easy to do. So now he feels that any surgeon can be trained. Good anterior segment surgeons can be trained. So what you saw was using a low temperature cautery to make a small flange in that phyoproline suture. So you keep the suture inside, and then you make your main incision. So it can be done as a standalone procedure or with phaco. And visualization. This is very important. I can keep telling this again and again. So as residents, you can start practicing intraoperative gonioscopy in your phaco cases or even in your small incision cases. You need a Swan-Jacob lens. So this is an MVR blade which opens. See, once you touch, you can see that bleeding. It's from already the blood in the Schlemm's canal. So if you can keep the head end slightly elevated, it helps you to reduce that bleeding. And again, putting visco nicely, without any air bubbles. This is unfortunate, there's a bubble, but you should not have a bubble as far as possible, so you can see nicely. So through that cleft now, you're going to put this phyoproline suture into the Schlemm's canal. So you're again going to understand that the anatomy can be beautifully designed, even with simple ideas like this of using a suture. So this suture, now if you see, it has to be carefully pushed tangentially, into the Schlemm's canal, 1 clock hour by 1 clock hour, very gently. At 180 degrees when it is on your side, the side where you're sitting, you may have a little bit of resistance, but if you continue to go, you can definitely cross that area, that resistance area. And if you want in between, you can make sure by doing a direct gonioscope and checking it. And this is using the Swan-Jacob lens, what you're seeing, the angle. And you can see now the suture is on the other side. So that's the suture now which has come 360 degree, again to your cleft. And it's so important that you need to go on top of the suture now when you're going to retrieve it. If you're going to go down, then it can get locked somewhere. So you have to go on top of the suture. And some of this forceps are very important. What you use is the MST forceps. It's very important for holding the suture and pushing it and driving it through that area. And you can see this is a small kink which we done to begin with, just is to realize that you are almost finishing the 360. Sometimes you keep driving and it doesn't come. It may be going in some other suprachoroidal space. Just to feel that kink. And now you hold on top. See the flange there? You hold there. And then that's what is a trabeculotomy is. So you start the trabeculotomy here, and at some point you have to remove the lens, and then use your McPherson forceps on the other hand to gently do a 360-degree trabeculotomy. That's what the suture does now. So now you're doing a 360-degree. It's inside the angle. Now you're cutting through the trabecular meshwork, and you're doing a 360-degree trabeculotomy. So some people are not very happy because you're damaging 360-degree of angle, but it works very well. Even moderate to severe glaucoma we are doing, but we have to look at long-term results. There are 5-year results now and even 10-year results being analyzed by Davinder Grover, but we need to see how this works on long term. The main issues are they have hyphemas which have to be taken care, and also sometimes they have peripheral anterior synechiae. There are a lot of reports which have been coming up, and now we'll look at something which is still not available, but it may be soon available. This is one suprachoroidal shunt which is now there, which is working to some extent. It's called the iStent Supra, and if you see, you can feel how small it is when it's on your one of your fingers. So it basically goes into the suprachoroidal space. So people have tried CyPass, gold implant and things like that, but after some time they found that significant endothelial cell loss happens with suprachoroidal shunt. So you have to be very carefully looking at some of these results. And getting into inflow procedures, madam also in the laser she covered, but basically so you are distracting the ciliary bodies. Again, it does in advanced glaucomas where your surgical risk is there, you can do this, or in blind eyes where you want to reduce the intraocular pressure. You do a diode cyclophotocoagulation. It can be a continuous wave, and now you have micropulse, where you can just sweep, and then some good results have been there even for seeing eyes. And then this is the old way of doing. We still do. Wherever there is no diode laser, you can do a cyclocryo. It's very painful post-operatively also, but it works very well to destroy the ciliary body and reduce the secretion. So this basically reduces the inflow. And finally, on the endoscopic cyclophotocoagulation, basically, it's an endoscope. You visualize beautifully the ciliary body, and then you can calculatively destroy the ciliary body, the ciliary processes, so that you have a control on how much destruction you're doing. When you're doing it from outside, to transclerally, you don't know exactly how much you're doing. But when you're doing internally, you're visualizing like this on a screen, and then you can see that shrinkage of the process which happens. That's the so you can do how many clock hours you want depending on how much of pressure control you need. So this is a very well controlled way of doing, and it's called the endoscopic cyclophotocoagulation. So now, all these options are open in front of you, but the point is, which would suit what is a bigger question. A lot of evidences are coming up, but it will be nice for you to know some of these techniques which are already being done here. But as young residents, I'll tell you, other than your exams, start practicing intraoperative gonioscopy, because that's going to be the future. Because I saw the evidence of 2022 Mediclaim data. There is no more trabeculectomy. There are only tube shunts, lasers, and some of the surgical options which I just listed. So prepare yourself for the next generation, and that will be my small piece of advice to end. Thank you.
Thank you, Dr. Venkatesh, for that excellent demonstration of videos. And at the concluding presentation of this session, I invite Dr. Vanita Pathakre again for a presentation on MIGS, a new paradigm.
Hi, good afternoon now. I hope you guys are not hypoglycemic. But this MIGS is what has made glaucoma interesting, believe me. Previously, as Dr. Venkatesh put it, unfortunately, we only had one surgery, and that surgery was quite destructive. Now, if you look at entire medicine, now this is open brain surgery. An aneurysm is being clipped okay? That has become less and less. And aneurysm surgery looks like this now because neurocoiling is done. However expensive it might be, a patient accepts less invasive procedure compared to open surgery. That is open heart surgery being done, and as you all know, I don't need to tell you, eye stents have taken over. Not eye stents. And the cath lab is where majority of cardiac work is done nowadays. But in all of medicine, the fallback is still the open surgery. Please remember that. And therefore, I will also say that you cannot get away without learning trabeculectomy if you are going to be practicing glaucoma seriously. The scene closer to home, meaning ophthalmology, we used to have ICCE, intracapsular cataract surgery. Then we moved on to ECCE. Then, we still have SICS. SICS is also pretty destructive to the conjunctiva as well as the sclera. And of course, you could be using a lot of sutures. So what do we do now? We use 2.2 millimeter or some even less. And we have at our disposal some state-of-the-art equipment, which combines some very high-end, very precision lenses in cataract surgery. And of course, why should glaucoma remain behind? Cornea too, from PK, they will move to DSEC, to DMEC, to DALC, to whatever, all right? So let's take it in perspective. Anti-glaucoma medications do form the backbone. But we know that more than 40% require more than 2 medications after at least 2 years to control IOP. And it's only prostaglandin analogs that control 24 hours. The others actually don't have. The good thing about medications is that they utilize your natural pathways, meaning suprachoroidal, PG analogs, ciliary body. Most of your drugs actually cause decrease aqueous production, and now we also have ROCK inhibitors that target the trabecular meshwork. But anti-glaucoma medications have a lot of limitations. Lifelong commitment, meaning issues of compliance, adherence, real issues, real-world issues, recurring costs, real-world issues, side effects, and quality of life. We don't think about that, okay? And of course, ocular surface disease. When it's mildly red, we all ignore. We put our heads inside the sand. We don't want to see. But you can see the subtle lid signs on the right side here. Actual follicles, this is a physician, unfortunately. He's got glaucoma and he developed an allergy. Same here. You can see the varying degrees of redness. And if there is no redness, look at the orbitopathy that is being caused. The dark circles, the sunken eyes. This 23-year-old looking like a 53-year-old. Very smart young lady, unfortunately, looking very aged. Cicatricial changes. So much so that this gentleman developed ectropion and resolved only after removal of the drug. Same here. Very, very intense ocular surface disease that only after removal of the noxious agent recovers to its original self. Same as this individual. So traditional approaches of glaucoma, unfortunately, uses a pathway which is not natural, not the trabecular meshwork, ciliary body, suprachoroidal pathway. It uses subconjunctival drainage. And it is this subconjunctival drainage that is its limitation. Although trabeculectomy was and continues to be the mainstay. So do the tubes. They also drain subconjunctival. You remember, but the bleb is formed far away from the limbus. So that bleb is the one that can lead to failure, both in trabeculectomy. As you can see, we want a trabeculectomy which has low, diffuse, posteriorly directed blebs, and you want it repeatedly, on a repeatable basis. But that does not happen. Unfortunately, blebs start failing, and they start looking something like that, or fails completely, and they start looking like that. And these kind of blebs, unfortunately, are also predisposed to blebitis, bleb-associated endophthalmitis. I too have my share of them, unfortunately. This gentleman did well. He came just on Saturday, and he was fine. But
what about this gentleman? In 2019, he first came to me, very ischemic bleb. At that time, there was no problem, but he came back to me with blebitis. You can see the foci, the multiple foci of infiltrates in the bleb, all right? And he's resolved, but his leak hasn't. So it has to be repaired. So it's, you know, obviously in glaucoma, things are a lifelong process. I'm not going to go through the details of side effects of trabeculectomy, but you know they can be sight-threatening. And so, in my opinion, we should be reserving trabeculectomy to help individuals who present with these kind of visual fields. Glaucoma drainage devices themselves also are pretty effective. They form a bleb away from the limbus. And unfortunately, because of the encapsulation that might happen more with valve devices, you can also have fairly high failure rate. And they too have a huge number of complications. I don't think I will go through them, but what I'm trying to say is that there is a gap between anti-glaucoma medication and current traditional, let's put it that way, surgical options. And it is MIGS that is helping us to bridge that gap, that void. Okay, none of the current MIGS as they are competing with trab or tube. So their profile, where you are indicated, is very different. So what do? Like medication, they utilize the natural pathways. So they're from mostly inside the eye. Ab internal, they are not utilizing subconjunctival drainage other than the MIGS plus devices. I will show you the categorization. So they cause minimal trauma to tissue. They are faster, safer, rapid recovery. From the patient point of view, very important, almost like phaco. And needs a new skill, that is intraoperative gonioscopy. We cannot stress any less. You need to acquire that skill to be able to do this. So in what kind of cases do? You do them in mild to moderate glaucoma. Please remember, mild to moderate on visual fields, right? And they have to be open angle, even post LPI if they open up, you can do them. They have difficulty taking medications, side effects or complications, or poor compliance. So the current MIGS, I've given a very simplified classification where it could be TM or canal-based, can be which you can stent, which you can dilate, or which you can do a trabeculotomy for, or your suprachoroidal devices, or your cycloablation. And the MIGS plus devices, which still form a bleb also. Now, suprachoroidal MIGS plus not available in India. We do have the eye stents, which are available, and we have a whole host of procedures that we can do with trabeculotomy. And of course, we also do have ECP. So procedures that are required for the MIGS that are available in India, you need open angles. You need open angles. The only procedure which you can do without worrying about angle status is endoscopic cycloablation, right? So let's take each one, the ones that are available in India, one by one. The eye stent, the single one, which looks like a snorkel, G1, generation 1. And the other one, inject, 2-in-1 injector, that is G2. This is the very first eye stent done in India, 15 September 2021. Things changed since then. It's a very small device. The G1, like you already seen, like a snorkel-like device, L-shaped, and the other one looks a little bit different, comes 2-in-1. The way you implant them is also slightly different. With the G1, you go almost parallel to the trabecular meshwork to implant it into the Schlemm's canal. Whereas with the G2, you go perpendicular to the trabecular meshwork. You make a dimple and inject, as you see there. So let's see some real videos now. This is all in wet lab. Here we are. This particular patient had G1. Actually, this is the first patient who got G1 in this country. You can see the device on the injector. Once you approach the trabecular meshwork, you go 15 degrees and then parallel to it, And as soon as you release, you get regurgitation. There's only place in the entire world of surgery where you are happy to see blood is here. Okay? So in some cases, you can also see it externally. It's a very small device. But this is 1 millimeter device, so that's why you may see it. But mostly you see it when you do gonioscopy, and you see it in the angle. And so this is iStent inject, okay? The first one going in, very soon you will see blood regurgitating. The video is not as clear, but you can see the red area around that inject, and that has been cleared, and you can see the inject nicely in position, and then you do the second one. Okay, there has been a lot of publication, meta-analysis as well, and it has shown that you can get a 30% reduction with reduction in medication. I'll not go into details, but there are many, many studies related to iStent inject also, which also shows the same. So what complications do you expect? I showed you a whole host of list for the traditional surgery. Here, maybe iris endothelial touch. Obviously, if you have experience, this goes down. Sometimes you get over and under implantation. There are maneuvers to manage that. You can get a stent malposition. You can get a little occlusion as well, and hyphema. But very transient. Usually only on the table. Very rarely you need a AC washout. Okay? Again, compare this to the whole host of complications that we talked about, subconjunctival drainage, okay? So, I will give you my data. There's very little Indian data, none that has been published. These are all that have at least 9 months follow-up. So, in iStent or iStent inject, I got a 25% reduction in IOP and an 80% reduction in anti-glaucoma medication, all of which was statistically significant. Have a look at this very first patient who got iStent in his eye. He had mild POAG, but he needed a trab, and that failed. And I didn't do the trab. It was done elsewhere, and he had several needlings also around it. And soon he was on 5 anti-glaucoma medications again, and his pressure had jumped to 29. This is how he looked with his medication. This was the appearance of his conjunctiva, and after his surgery, both eyes were done. He's 6'6", N6. His intraocular pressure is 17 on 2 drugs in the eye which had failed trap. He's happy. And 18 without medication in the other eye. He's very, very happy. So that's how he looks. He looked after. Second picture is after his anti-glaucoma medications were taken off, and this is how he looks now. He's very happy. Then the second, Kahook dual blade, you saw it yourself here in this particular video. I'm going to show you one that is not being done with cataract. The lens is absolutely clear. And this is a chap who developed angle recession glaucoma. His disc was relatively healthy, but unfortunately pressures were not controlled. So he was 20 on 5 medication, and he didn't want to do it. Young chap didn't want to do it forever. So you can see angle recession there. A very wide ciliary body band, and the Kahook dual blade above it to unroof the Schlemm's canal. I do 90 to 100 degrees. I don't do more than that. And I feel the results are good enough. So you create a cleft. You create a cleft which starts bleeding. Very soon you will see it starts bleeding. And when it's bleeding, you're happy. So the dual blade is expensive. It's not cheap. So a cost-effective way of doing this is doing what we call bang. Now this was first described by Arsham Shibani. He happens to be my co-fellow from the University of Toronto. Very proud of him. You can bend the needle. Just as you bend your capsulorhexis needle, you bend it forwards. You don't bend it backwards, okay? Bevel towards you. And you create a cutting edge, 45 degrees. Almost looks like a Kahook dual blade, okay? So this was a video taken by my fellow sitting right at the back. I acknowledge her work. So this is how you bend it forward. And I keep it 45 degrees. I don't go anymore. So in this particular case, after cataract was done, the needle was bent, and after the needle was bent, this is one of the intraoperative gonioscopes. I like these lenses better. And again, you can see how much clearer you can see the unroofing of the Schlemm's canal here. Okay? And on the tip, you can see the excised trabecular meshwork, which you can aspirate away. In the previous video, sorry, I forgot to show you a very nicely cut trabecular meshwork. So I just give you my results once again for BANG, which I have been doing much earlier than iStents. And these, although the data has only been collected for 6 months, sorry for that, but even then, 20% reduction and a whopping 95% reduction in anti-glaucoma medication. I'll take the results any day, right? And endocyclophotocoagulation, this is my passion. I feel that although it is destructive, everything is destructive. GAT is destructive. GAT destroys trabecular meshwork 360 degrees. Cahook dual blade destroys it for maybe 100 degrees. BANG destroys it for 100 degrees. So what we're doing is we're destroying only 180 degrees. You use the same near-infrared diode. It can be used for any glaucoma. Primary, secondary, angle closure, non-angle closure, doesn't matter. All right? You visualize the ciliary body, and the power you use is 1/4 that used for transscleral delivery. So it cannot be safer. Okay? You can combine it with cataract surgery. I do it all the time. So if you do it as standalone, you can enter corneal, you can enter pars plana, no problem. If you do pars plana, you need vitrectomy, and this is the sum total of complications I have faced with ECP, CME, fibrin, pupillary abnormalities. Okay? So just a video on how they are targeted. Laser power, not more than 500 milliwatts, whereas for transscleral, you start with 2000. Endpoint, whitening, and shrinkage, and you avoid pops. You don't want ciliary body destroyed. In the interest of time, I'll just move on. So I have done quite a few studies, and the key points from these studies are that complete success in all these 3 studies, one is pending publication, is more than 70%. That's like TRAB. So it's superior to phaco alone, non-inferior to TRAB. No sight-threatening complications, and definitely I have not seen any aqueous misdirection with this procedure. So to summarize, and I hope I'm on time, maybe not, MIGS are usually ab interno, minimally traumatic, safe procedures, okay, which preserve the conjunctiva. Please remember, you can still do a TRAB if it's required in future. It fills the void between medical management and more invasive traditional surgeries. It's indicated earlier in the disease, offered when patients need cataract surgery. Best time to do it. Safe and efficacious when the indications are appropriate and it's not competing with TRAB. Current MIGS devices are mainly for angles which are open, except ECP, as I explained to you, and usually combined with cataract surgery in mild to moderate glaucoma, and do not compromise either the conjunctiva or the sclera. So future TRAB is fine. And for me, the most important thing is that very patient-centric. It's safer, lesser number of post-operative visits, early visual rehabilitation, almost like phaco, reduction in anti-glaucoma medication, which has several advantages. Reduced chance of ocular surface disease, allergy, compliance, adherence, you name it, improves quality of life. Extremely limited data in Indian eyes. To end, I will say if cost were the only limiting factor, then there would be no stent surgery done, cardiac stents done in India, no neurocoiling done in India, okay? And just as CABG is the fallback for advanced cardiac disease, TRAB continues and will remain the fallback in. So it's up to you whether you want to have extra cutting, extra stitching in your eye, or you want a small device that is inside your eye, not even visible, for an eye to look like this 1 week post-op versus an eye to look like this 1 year post-op. Thank you.
So
I am inviting all third-year postgraduates to come and actually see it for yourself. I've got a workshop coming up on World Glaucoma Day, 12th March. You're invited. Thank you.
thank you, Vanita. And Harsh handed over the session to me 10 minutes late, but I'm finishing on time. And I don't want to stand between the PGs and lunch. So straight away hand over to Rolika.
Hi, so
Hope all
thank you
the-
so
yeah.
much for keeping everything absolutely on time. We are minute to minute on time. And there's this one little thing I want to show you guys. So this is the iFocus Insta moment of the day, unparalleled winner. That is Dr. Rakshit Agarwal. And it was very sweet of him. These people couldn't turn up here because they had an NMC inspection. So they're watching it online and they've sent a nice story out there. So, so it's like iFocus Live to the rescue. So we are live on Facebook and YouTube, and even so you just make sure that all of your pictures are taken at the lunch area with your Vibe Your Tribe, and the competition is on. So over to Rashmin sir. Now the people who are supposed to be in the Grand Viva competition, please stay back. Sir will be taking an elimination round for you guys. So I request Dr. Niharika Chaurasia, Dr. Gautam, all of you please come and sit on the second row in a sequence, please. So Dr. Niharika Chaurasia, Dr. Gautam, Dr. Vipin, Dr. Anurag, Dr. Farnaz, Dr. Kiran, Dr. Pooja, and Dr. Nishi. Yeah, that's perfect. So just line up right here.
Yeah, you would have to write down the answer. It's a written quiz. It's a quick fire 10 questions to two, three, 5, 6. Yeah, you just need to write the answer, and it's a MCQ. So just write which choice is the best choice for a particular question. It's just a quick fire elimination. Are all of you there? I mean, just make sure. Of course, of course. Of course, of course. We'll start in 2 minutes. Depends upon how many of you are there. It'll be around 10 or 15, so we'll finish in 15 or so. Oh, a lot of you started answering, or what? All right, are we settled? All right, if all of you settled, a quick housekeeping, write your name on the right hand corner so that we can identify who you are. How many of you are participating? Can you raise your hands? 1, 2, 3, 5. Okay, so we'll have 15 questions. There are no negative markings. It's an MCQ. Choose one option which you feel is most appropriate. If you're ready, if you've written your names, all right. First question is this. What percentage of patients on medium to high dosage of topical dexamethasone for 6 weeks develop elevated IOP? 20, 42, 66, 79. Percentage of people developing high IOP following topical dexamethasone following 6 weeks. 20, 42, 66, 60, 79. We'll be little fast since we are between the lunch. Netamycin may be effective in the treatment of all of the following infectious agents except Aspergillus, Candida, Fusarium, Mucor. Netamycin may be effective in the treatment of all of the following except Aspergillus, Candida, Fusarium, Mucor. All right. As we go on, we go to number 3. What is the anesthetic duration of topical proparacaine, which we all use? What is the duration of anesthesia when you instill a drop of proparacaine? 5, 10, 16, 20 minutes. How long after a topical instillation of proparacaine does the anesthetic effect persist? All right, shall we move on? Which optical principle is the basis of anti-reflective coating on the glasses and lenses? Which of this is the basis of anti-reflective property of your spectacles and lenses? Coherence, diffraction, interference, polarization. Which of this is responsible for anti-reflective coating on the glasses and spectacles and lenses? We move on to question number 5. You are doing a duochrome test and the patient says that letters in red color are better than green color. The letters in the red are clearer than the green. What is patient's refractive status? Is he overplused, over-minused, anisometropic, presbyopic? If the patient says letters in red are better than green, is he overplused, over-minused, anisometropic, or presbyopic? We move on to question 6. Which of the following does not distinguish optic neuropathy from amblyopia? Brightness test, color vision testing, neural density filters, and visual acuity with linear letters. Which one of these will not distinguish optic neuropathy of any cause from amblyopia? Brightness test, color vision test, neutral density filter, and visual acuity with linear letters. 7, one more neurophthalm. Which of this would not produce optic neuropathy? So ingestion of all of these will produce optic neuropathy except one. Isoniazid, methanol, ethambutol, ganciclovir. A relatively simpler one. Which one of this will not produce optic neuropathy? Isoniazid, methanol, ethambutol, ganciclovir. Question 8. Neuroblastoma is characterized by all of the following except metastasis from the adrenal gland, possible spontaneous regression, poor prognosis if diagnosed before 1 year of age, periorbital ecchymosis. Neuroblastoma is characterized by all of the following except metastasis from the adrenal gland, possible spontaneous regression, poor prognosis if diagnosed before 1 year of age, and periorbital ecchymosis. Move on to little more than halfway there. 9. Each of the following may be associated with Duane syndrome except. Each of the following would be associated with Duane syndrome except thalidomide, Marcus jaw winking, Goldenhar's, glaucoma. Which is not an association of Goldenhar syndrome? Thalidomide, Marcus gun, Goldenhar, glaucoma. Move to question number 10. The 5 mm raised skin lesion with central ulceration is least likely to be which of the following? A lot of least likely and except questions. Keratoacanthoma, squamous cell carcinoma, basal cell carcinoma, malignant melanoma. The 5 mm raised skin lesion with central ulceration. It's not likely to be which of these? Keratoacanthoma, squamous cell, basal cell, malignant melanoma. We have 5 more questions to go. Question 11. The most common form of ptosis is involutional, neurogenic, myogenic, mechanical. Which of these 4 causes would be the most likely to cause a blepharoptosis among these 4? Involutional, neurogenic, myogenic, mechanical. Question 12. In congenital nasolacrimal system obstruction, where is the level of obstruction? Common canalicula's lacrimal sac, wall of Rosenmuller, wall of Hassner. In congenital NLD obstruction, where would you find an obstruction? Common canalicula's lacrimal sac, valve of Rosenmuller, or valve of Hassner. 3 more questions. Question 13. Trachoma can cause all of these except districhiasis, punctal stenosis, conjunctival scarring, and tropion. Which of these you would see in trachoma except districhiasis, punctal stenosis, conjunctival scarring, and tropion? Second last question. What is the most common cause of unilateral childhood exophthalmos? Capillary meningioma, thyroid-related ophthalmopathy, orbital hemorrhage, orbital cellulitis. Unilateral childhood exophthalmos. Capillary meningioma, TRO, orbital hemorrhage, orbital cellulitis. The last question for this informal elimination round is all of the following clinical findings can be associated with golden hours except eyelid colobomas, lipodermoids, Duane syndrome, proptosis. What would you not see in golden hours? Eyelid colobomas, lipodermoids, Duane syndrome, proptosis. Make sure that you've written your name on the right hand corner. Submit it to Rolika. There are no negative answers, so don't worry if you have guessed for the answer. And we will declare it at the end of the lunch. Thank you so much. Ultimately, she will.